Good morning, everyone. It seems like a good amount of folks have joined, and we are going to just begin with our program. Please let me know if you can hear me well, if you need me to project my voice and such. But good morning again, everyone, and welcome to our annual Isuroon's International Women's Day Conference. I am honored to serve as your Mistress of Ceremony for this meaningful and empowering space dedicated to maternal and child health today. Today, we come together to celebrate the strength, resilience, and achievements of women worldwide. As we mark this special day, we are here to amplify the conversations around the health and well-being of mothers and children, and to be part of a global community committed to making a difference. Before we dive into our agenda, I want to take a moment to express our heartfelt gratitude to our sponsors, Hennepin County Children and Family Services and Peace of Mind Care Center, for their generous support and partnership in making this event possible. Your dedication to promoting the well-being of families and children in our community is truly commendable, and we are grateful. Throughout the next few hours, we will hear from a diverse group of speakers. I am so excited, who will be sharing their insight and expertise on various important topics related to maternal and child health, from discussions on Black maternal health to understanding maternal depression and navigating trauma after loss. Our lineup of speakers will deepen our understanding and inspire us to take action. I'm so excited for y'all to embark on this journey. I encourage each of you to actively participate, engage with our speakers, ask questions. Our Q&A box is open, and share your thoughts. Let's use this opportunity to connect, learn, and contribute to a vital cause that impacts lives universally. Thank you again for joining us today. Oh, and happy Friday. So let's just dive in. It's my honor to introduce a visionary leader and the driving force behind Isuroon. Oh, can you take off this slide, please? Thank you. Thank you, Isaac. I'm so excited to introduce our CEO and founder, Fortune Welly. Fortune's unwavering dedication and passion for empowering Somali women and their families have been the guiding light for Isuroon's impactful work in the community. I am in awe of her commitment to breaking barriers, fostering inclusivity, and promoting cultural understanding. Please welcome Fortune.
Oh, you're so awesome, Najma. Salam alaikum, everyone. I greet you to peace and prosperity. Najma, Isuroon team, I'm so grateful and so proud of you, everything you do for us and everything you do for me. Happy International Women's Day. I want to make sure that we start with the Quran too, because it's going to be a day of celebration, also a day that we talk about the reality of HIPAC women's maternal child health. So I'm going to read Qul Huwa Allah. Bismillahir Rahmanir Rahim. Qul Huwa Allahu Ahad. Allahu Samad. Lam yalid wa lam yulad wa lam yakun lahu kufuwan ahad. We believe in God and everything He gives us. Amen. Isuroon was started to need to have a space for women and their families, including men. Let me just say that, including men, to have their own needs met, but also utilizing their assets. And now we're 30 years old, and we're still learning. We're still doing a lot. Working on equity and inclusion and economic upward mobility has been one of our core values. Today, we selected maternal child health. The reason being Minnesota is still ranking one of the worst places for HIPAC women and their families when it comes down to maternal child health. I am so grateful for all the speakers, for the sponsors, our team, and everyone who contributes their time and their tears and their hugs and their sweet tea that we offer most of the time in our building. This event would not be an event if we don't express our sadness and what's happening in Palestine, women and their families. We're praying for quick resolution and peace in that area, and Palestine and their families being protected by God and our whole community. This event is more than an event. It's a platform for meaning and discussion and insight that will deepen our understanding of maternal child health. We've been talking about infant mortality rate and maternal child health issues since I came to Minnesota, which was 23 years ago. But it's still nothing is happening in terms of reducing the infant mortality or maternal mortality of Black and Brown women. So the work goes on. Today we're hoping that all the discussions and everything that you're learning, that gives you some power and some knowledge for you to take on and try to make the better life, to better experience for the mother and children of Black and Brown people. So my hope is, as Najma said, you stay participant, stay active. I know it's Friday, everyone is tired, but be active. We wish that we would be meeting in person, but this virtual thing is so amazingly alternative to doing things these days. Right now, I'm so excited to introduce, is Holland Representative Hassan available? Hello, Haraya. So I don't know how to introduce to her. I'm beyond proud. Hassan is not only one of our leading change makers, she's a mom, she's a social worker, she's a fighter for social equity and women's agenda, and she's a change maker. There is a Somali word called Horeya, which means a liberator. I was trying to Google that word today, hold on, to see what that word means in English, but I couldn't, so I'm gonna call you Horeya. And we love you so much. We care about you so much. Thank you for showing us all the love and the advocacy that you do for us and for our families. Please welcome.
Good morning, everyone. That was overly done. Okay, that introduction was beyond what I would say about myself. Happy International Women's Day. Happy Friday. I hope everyone is doing great. My name is Hoden Hassan. I represent District 62B, which is in South Minneapolis. I have been doing this work for 6 years, and this is my last year. I am retiring from the legislature. Today is International Women's Day, and what a perfect day to talk about maternal health. In the legislature, when I joined 6 years ago, I think there was only one Black legislator. There were two, but Ilhan Omar left to go to Congress. So Rina Moran was the only Black woman legislator in the legislature when we joined, myself and Ruth Richardson in 2019. And I remember sitting in Rina Moran's office and talking about Black maternal health, and looking at each other and saying that how are we gonna push this agenda and how are we gonna shed a light on this. Fast forward 6 years later, there's a lot that has been done, but there's a lot that needs to be done. Black women, even while Minnesotans have like lower overall pregnancy related mortality ratio, but Black women have 2 times the normal average that we have here. And data shows that Black women are overrepresented in pregnancy associated related deaths, which it's something preventable today. There are a lot of reasons why that's the case. Someone the other day came to my office, I think it was Wednesday, a group of young doctors that I was meeting that are Black women told me that even today, they said the most racist place to be in is healthcare. And I'm like, should we compare notes? Because the most racist place to be as a Black person is the legislator. And they were talking about, how even today, still providers believe that Black people can tolerate more pain than other people. So when a Black mother is giving birth and she, says that she's in pain, that's, underrated or underscored. We sometimes I hear stories, horrific stories about, Fairview or other providers saying, people saying that, oh, they don't want to, this Black woman don't want C-sections, let them just suffer. We hosted 2 Black maternal health conferences in the last 6 years I've been here. And the stories, whether they're coming from the African American community or whether they're coming from the new African immigrant, is the same. The story of pain and suffering and near-death experiences are all the same. I remember, a woman who shared her sister's story. She said, my sister was a nurse. She got pregnant and, was following throughout whole pregnancy. She was seeing the doctor. Everything was fine. No one alarmed her. And then, few days after she was gonna give birth, the doctor was like, oh, your blood pressure seems very high. She was like, well, I've been getting, prenatal care, and no one has ever mentioned that. They were like, oh, it's possible you're gonna have preeclampsia. She had preeclampsia and she died after she gave birth. And that is a woman who was a nurse, who was in the medical field, who has gotten all her prenatal care. And that tells you there is still negligence. Even educated Black women who are doing everything that they're supposed to do are still dying, preventable death. The work that we have done at the legislature, I should focus on, is adding morbidity to maternal mortality. That's House File 53. That House file has been here. Ruth Richardson is no longer the legislator, but she has carried that bill for 5 years. And this year, Representative Mary is carrying it. And then we also have House File 819, fibroid education. We have heard so many stories of issues with fibroid in the Black community. And nobody studies that, right? People go to their doctors, oh, you have fibroids, you are bleeding heavily every month, and then you are anemic. That's very normal, as many of you guys know. And there isn't a study of why there are more Black women experiencing fibroids and heavy bleeding than other women. That has never been studied. So we're asking University of Minnesota to partner up with community entities to complete a study, and that House file has not been passed yet, but we're still pushing that. House File 1324 is the certified midwife licensing, and then House File 52 establishing the right for a pregnant person to have a support person while they're receiving care. And then there was several that we passed that are already in law. Why are we doing this work? Because this is work that is important. These deaths are deaths that are preventable. When somebody gets pregnant, it's an excitement, it's a joy, but it's also scary, especially for Black women, because knowing that, your mother talks about, crazy stories and really scary stories, and your grandmother talked about other crazy stories, and the saga continues. So how do we break this cycle of suffering for Black women, and how do we make this the joyful that it is? Yes, having a baby is scary because it's an extra responsibility, but the extra burden of like, am I going to die while giving birth, which other people most don't worry about, but Black women always often worry about, and some it becomes a reality for them. That is the work that needs to continue. That's the work that we need to have next year. This time we need to have a conversation that says, hey, we have advanced Black maternal health. There are less women dying because of the work that we're doing. There are less women dying because of the education that's going on. There are less women dying because of the awareness, and also educate the community about their rights and the resources that are available. The other thing is that, you know, many people don't trust providers. Many people don't have that relationship, good relationship. There is data out there that says if if your child has a Black provider, they are much more likely to have a pleasant experience receiving healthcare services. We don't have enough Black providers, but we got to educate our community, and we got to educate the mainstream community about how to provide care to Black families, to Black mothers. I myself remember, going to the doctor. My son is 19 years old now. He's in college. When he was 5 years old, he has ear infection. The doctor comes in, doesn't even look at his ears, and just writes a prescription for me. And then I'm like, what's this? And he told me oh, he probably has ear infection. Probably? Well, I would like for you to look at his ears and tell me he has an ear infection. He said, it doesn't matter whether I look at him or not. He probably has an ear infection. I told him, I'm not taking this, and I don't want your services. I'm going to go somewhere else. So even if families know to advocate for themselves, no one should tell you that without even looking at your child, oh, your child has this or your child has that. Do families know that, hey, if I don't like my provider, I can go somewhere else and find a provider that I like and build a relationship with that provider? Many people don't know that. Many people have like that one terrible experience with at the doctor's office or at the hospital and run away from hospitals, and then not getting the services that they need and not getting the care that they need. And that, makes their lives even worse, because you need that care. You need to build that relationship with that provider. So we're doing our part at the state legislature, trying to push legislation that makes Black maternal health outcomes better and easily accessible, and reducing the number of fatalities that are related to Black maternal health. But we also need the community to work alongside with us and provide, testimony when we need, and show up and demand, not only to the Black legislators, but other legislators that represent you. You need to care about this issue. This is an issue that's important to my community, because as we know that this is the future of our next generation, and if we don't make it right today, this cycle won't be broken, and the struggle continues, and we don't want this struggle to continue. We want to make sure that Black women can go to the doctor and have a pleasant experience while they're, giving birth, or while they're receiving prenatal care, or while they're receiving care in general. The doula program, I remember we talked about the reason why many people didn't want to be doulas is because the pay was so low. We increased the pay, and then I'm finding out this year that when we increased the pay, somebody had a great idea of saying, oh, let's make them their own providers. So now Black and brown women do not want to deal with the, billing and being their own provider and the paperwork with DHS. So that is, pushing many Black and brown women out of this field, and saying that we do not want to provide we don't want to do our own billing, which I don't blame them, because who wants to do all those paperwork? I see that I'm running out of time, but it was an honor to be with you today. It's great to be here and have this conversation. This is a conversation that's near and dear to my heart. Not only am I a woman, but I'm also a mother who has 2 children, and I care about this issue. So thank you for listening to me, and we'll stand for questions.
Yes. Thank you, Representative Hadan Hassan. Your tireless advocacy for women's health and dedication to the Black maternal health is not only inspiring, but also a call to action for all of us to support and amplify. Thank you so much. We have the chat open for anyone who wants to ask questions. Please engage. This is your opportunity. You have a representative right in front of you. Go ahead, ask questions, please. Caroline, yes, welcome. We're excited to have you today. Let's see. I guess everyone has no questions. Everything's been answered.
Wow. Well, I can ask question. Representative Hassan, the U of M research working with the community, can you talk about a little bit about that? The U of M and having communities of color research together, that gives me a little, you know.
Okay, let me, I'm gonna pull up the bill itself, so
Okay.
I'm not, it
And we,
is
what was the bill
819.
number? I can look at it too.
It's, it's up, so it's, this is the old bill, I don't see the new one, so this bill, what it does is, it creates an awareness campaign about fibroids. Like I told you guys, every Black woman that I talk to, or every other Black woman I talk to, talks about knowing somebody who has fibroids in their family, right? So this is very common in the Black community. So this bill, what it does is, A, it creates a public awareness campaign, and then B, it does, it says that we should do research, but the research is, I don't see, I thought it was, no, it's asking Department of Commissioner of Health to create a research group. So it's not the UFM. This is the old one was with the UFM, but the new one I'm looking, it's House File 819.
Right.
So
Wonderful.
it is, the old one asked, because I remember some folks had some heartburn with UFM leading that research. So we're asking, so in this bill, we're asking the Department of Health to partner up with community groups and do the research. So it has not, you know, the bill has not passed yet. So I'm hoping when it passes that we will have a conversation with Department of Health and figure out who are the stakeholders that they should work with.
Last question. You're a mother and you're a social worker. We can't close this deal today without talking about maternal depression and depression in that world. What would you tell HIPAC women and other people who try to help us? Like, word of encouragement? We know that if, for example, an immigrant mom or Black mom admits, the word is, if she admits being depressed, she believes the children will be taken away from her. That is a battle we've been against. So what can you tell to those moms and their families to say we can't just be silent about depression and all that stuff?
I'll say this, postpartum depression is real. It happens to everyone. The only difference is that it all depends on where your emotional health was at before you had the baby, right? And many people are dealing with so many different things that our emotional health is not at where it's supposed to be. So anything, when you have so many things going, and especially trauma, if you come from traumatic background, anything can tip you off. One sleepless night can tip you off. So if there was one thing that I would tell, you know, mothers, is that, first of all, this is real, and this has nothing to do with your faith. It has nothing to do with your ability. It has nothing to do with who you are. It does not discriminate. It happens to everybody. You really need to seek services. Your children will not be taken away because you have postpartum depression or you seek services. And then I will say, when you feel overwhelmed, find a friend, find a family member, take a break. It's okay to take a break. I think one of the biggest problems that as Black women we face is that society tells us that we're so strong, we're so resilient, that we don't break down. Well, guess what? We're human beings at the end of the day. Yes, we break down. Yes, we're like everybody else. So it's okay to ask for help. It's okay to take breaks. When you are overwhelmed, ask a friend to watch your children, take a walk, go to the lake, take a break, go to the mall, whatever makes you happy. Do some self-care, because self-care goes a long way. And then if this is serious, go talk to a provider. All you might need is just a pill or two, or you might just need to talk to a therapist and just unload what's going on with you. So it's not something that is so terrible. And I know there's a stigma related to this in our communities. The Black people don't think that we should talk to therapists. Black people don't think that we should take medication for depression. Those things are real. When you have a headache, you take Tylenol. When something doesn't work in your emotional health and your brain isn't functioning the way that it should, you should do everything absolutely you can to fix that so you can function the way that you're supposed to do. I'm not a big fan of medication, and I'm not advocating for pharmaceuticals because I fight with big pharma all the time. But there are so many different ways to stay emotionally healthy by being connected to family and friends, self-care, taking breaks when you need, surrounding yourself with positive, environment, all of those things. And mothers, please, please, please take a break. Ask your partner to take care of the child at night so you can at least sleep for a few hours or half of the night. Ask your mom, your siblings, somebody to help you when you're overwhelmed, when you need sleep, because I had two children, and there were times that I was so overwhelmed that I feel like that I just want to disappear. And you should not let yourself get there. You should always find where your limit is, and when you feel overwhelmed, take a walk. Even taking a bath sometimes, just soaking in salt and some, having few candles, and you just have to know what's good, what works with your soul. For me, smell is really good for me, and taking walks. I'll take a walk. I like the fresh air, or I'll take a bath and have like scented candles. So the person has to know what's good for them and what speaks to their soul. But please, whatever you do, do not be ashamed or feel guilty about seeking support and seeking services.
Oh, I'm muted. Thank you so much, Reverend Hassa. Ramadan Kareem.
Ramadan Kareem.
Yeah, salam alaikum. Thanks, Habibti. Najma.
Thank you so much, Representative Hadan. Our sincere appreciation. Thank you. Up next is a presenter I'm very excited for. I'm honored to introduce a distinguished leader in the movement to end violence against women, Miss Umi Hankins. Welcome. Please, if you could spotlight Umi, that would be great. Umi is a remarkable human. Her career spans nearly 50 years. She has been a driving force in empowering women and girls, as well as the co-founding the National Institute of Transformation and Healing in the Black Community, LLC, and Black Sage Collective in Michigan. Our Q&A box down below is open. So throughout her presentation, please keep the questions trickling in. We will read them and ask Umi at the end of her presentation. But if something comes into mind, just put it in the chat box, please. Without further ado, let's extend a warm welcome to an extraordinary advocate and educator, Miss Umi. Welcome.
Well, thank you so much, and good morning to all. I truly appreciate the fact that we have so many people that have joined us this morning. I cannot tell you how much I enjoyed the previous presentation and was listening so intently that it was like, oh, it's my turn. I was so involved. So I considered it a gift for me to be able to be in this space with you. I think as our presence is is evident that we all bring our own personal experiences to the work that we do, whether that experience included some of the issues of infant mortality or not, or maternal mortality or morbidity, whether we come here with a clear mind or we have tremendous historical backgrounds on how life has impacted us, so that at any point in time we could all suffer from depression or be you know be inflated by the trauma that we have experienced in our lives. So again, I thank you for the ability to be here, for my presence, and for all that I've heard thus far and all that is to come from now. I'm here with you today because I'm going to provide a presentation on the mothers of gynecology, enslaved women who have laid the foundation for modern gynecology. And so to do this, I do have a PowerPoint slide that I'm going to load up, and then that way we'll be able to follow along. Again, if you have questions, as was stated, please put them in the chat. I won't be able to see them necessarily, but I know that the team, that the Isuroon team will let me know about any questions that are coming up that I should address. All right. So I always talk myself through sharing a screen. You have to forgive me for that. Just trying to make sure I'm covering all of my steps. So I am thinking and talking my way through. Everyone should see the screen at this point. Um, I want to do a slideshow. All right. So can everyone see the slideshow? Are we all attuned with that? All right. All right.
Yes.
All right. Thank you very much. I appreciate that. And I'm going to close out so many other things on my screen. So that's just showing for me. So thank you again for joining. As I said, my presentation this morning is about the mothers of gynecology, enslaved women who laid the foundation for modern gynecology. This is a topic that is really close to my heart. Just a couple of weeks ago, I had an opportunity to go to the conference that was entitled Mothers of Gynecology. And during that conference, then I was able to learn even more than I knew before. It was absolutely tremendous. I wanted to mention, based on the last presentation, that there was a Dr. Pierre Johnson that presented at the conference. This was the third conference, by the way. There was a Dr. Pierre Johnson. He's out of Chicago, medical doctor, gynecologist, and he specializes in fibroids. And just unbelievable, the information that he presented to us. And so I offer that as a resource to us and to you as you continue to look at those issues around fibroids in women, and finding resolution for that. As I said, we all come to this work with diverse histories and the way in which we have experienced life. And I had to have a hysterectomy some years ago when I was around 40 years old because of fibroid tumors. My sister had a hysterectomy. One of my daughters had to have a hysterectomy, and all within this Black community, when there may be other alternatives that could have been offered for us or to have minimized what we experienced. So Dr. Pierre Johnson in Chicago was the person that brought more awareness to me on this issue. All right. So the mothers of gynecology. And let's see here. All right. So, when I talk about historical issues, because the Mothers of Gynecology does delve into historical issues of enslavement of Black women in the United States and North America, and it's going to the past. It's looking at the past. And when I refer to that, I look at it from a standpoint of an African language, Twi, that brings to us the reality of the Sankofa bird. And the Sankofa bird is a mythical bird. It's not real, but it brings to us the mindset, the experience of what it means to look at our past and then be able to move forward with our future. So you can see that the Sankofa bird is going back and picking up this precious egg on its back, because we all carry our histories on our back, and it's picking up this precious egg that's carried on its back, and it's still moving forth. So looking at our history is not meant to have us to be traumatized, or not meant for us to stay in the past and not think that there's no hope for us in the future, but it's meant to send the message that in order for us to move forth, we have to understand where we've come from. We have to understand our experiences that we've had, and then be able to take that and create a pathway for resilience, a pathway for survival in the future. And so we use the Sankofa bird, which means go fetch it. Sankofa is a word that means go fetch it. Go back to your past and understand the realities that we've experienced, and then keep moving forth to hope, transition, transformation, and resiliency for our future. So the goals of this presentation are really simple and very broad based. I want to identify the impact that historical oppression has had on health determinants for Black women of African descent today. So as we live in our communities, whether you're in Minnesota, as you are, I'm in Detroit, Michigan, and we have a lot of other people on our webinar today that may be from other communities, but it's all of our communities who recognize ourselves as Black and Brown, or being of African descent today in our communities, and the way in which that has impacted our health. How have the issues of historical oppression impacted our health, not only in the past, but in our today living worlds as well? And how do we heal through storytelling of these narratives? We want to be able to look at the past, understand the narratives through experiences that were had, and bring them forth to our lessons learned today, so that we may be able to heal, and we may be able to continue our journeys and offer a pathway for our next generation, for our children's and our children's children, that will be enriched with strategies to heal and understanding what has happened to us to really bring us to this point. So, the first thing I want to do is define this issue of Blackness, because in the United States of America, we talk about Blackness, we see it in our census. I, as a Black woman, and all of my friends and constituencies always talk about this issue of Blackness. We don't leave it behind, because it's woven throughout our lives based on the historical issues that we've experienced. And so the census really says that a Black person is a person having origins in any of the Black sub-Saharan racial groups of Africa, and identifies then our roots, our origins, as having some impact on us. And so this definition brings into its meaning colorism. It brings into its definition that it's about Black people, sub-Saharan people in Africa. No, all of them were not Black. We have people of Indian descent who live in Africa from historical times. We have people who were white and colonizers who came to Africa. But we're telling this story about this sub-Saharan group of people who live in Africa and then were enslaved through the transatlantic slave trade and other ways as well. So in defining Blackness, we also look at it here in North America and give it other definitions than what the census just said. It was like, you're Black if you have one drop of Black blood, so you can go back 5 generations, but if you have one ancestor who is Black, then you're recognized as being Black. There were other terms that were used for our Blackness, being Negro, being mulatto, being colored, being Creole, being of African descent, being African Black or unmixed Black, totally of African descent. having, passing for white, which means that you have mixed blood with the white population, and may have been able to, that your skin was so fair that you were able to pass for white. And many people in our United States did that, who were, their mother could have been raped by the plantation owner, could have been raped by other white members of the community, or later in history could have had the opportunity to have a relationship, a consensual relationship with someone white and bore children, but you were white. And instead of saying that one drop rule applied to you, despite the way in which you came to this presence, but the one drop rule, then you opted or were able to pass for white. And people of color, of African descent, or the African diaspora, those are all ways that we talk about our Blackness. Those are all ways that we need to look inside of ourselves and define your Blackness for you. I define myself as being a Black woman, and very proud and unapologetically a Black woman. And how do you define yourself in your racial identity, as that was defined in our census or other ways? But race is a social construct. It's a human invented classification system. It was invented as a way to define physical differences between people, but has more often been used as a tool of oppression and violence. And I raise this issue because race itself, our use of the word race, is artificial and has been the underlying foundation for driving oppression in our community. Our identification of Blackness was used to oppress us. And so, although I say that I am unapologetically Black, and I'm unapologetically Black because I'm proud of my culture, I'm proud of my color, I'm proud of my ancestors, I am unapologetically Black and willing to do that, but I deny this issue of being inferior. I deny being dehumanized. I deny this experience of marginalization that we suffer through because of the fact that we are Black. I accept my culture. I accept the beautiful parts of my life, and I deny this imposed dehumanization that's placed on us because of our Blackness. And because of that, then we have to look at our past. We have to look at our history in order for us to be able to be proud and to have this resilience that we need to move forward. Intersectionality is this issue of a basic premise of we have multiple identities. We do not only identify as a race, of a human race, or being Black as that construct is created, but we also have other ways that we identify. And I want to make sure that we honor those. We honor our gender. I honor the fact that I am a Black woman. We honor our class. We honor our sexuality. We honor our immigrant status, or other ways that we identify. We honor our the way in which we identify our sexuality, whether it's LGBTQ, whether it's heterosexual. We honor all those ways in which we identify, and all of those things intersect with our Blackness. And Kimberly Crenshaw, Dr. Kimberly Crenshaw, came up with that term because it is by virtue of those intersections, my intersection of being a descendant of Black enslaved women who were sexually brutalized over the course of slavery and over the course of the continuations of the legacy of slavery that existed. So I honor those ways. I honor my ancestors for their struggles that they went through. I honor them for doing what they did to lay a path for life to be easier for me. And I honor the way in which we come together to host these discussions so that we will provide a pathway for the children that we also bear, that we birth, and that we help to raise and to be able to experience our lives in a healthy way. So this is some information from intersectional reality presented by Dr. Kimberly Crenshaw, which I will share with Isuroon. And then that way you will be able to look at some more of that. And I talk about historical context because I don't want us to forget that our historical context goes back before being in the United States of America, that enslavement was something that didn't originate in America. Enslavement is something that happened across the world in different formats and different ways that it was experienced. But it was not only germane to having Black Africans stolen from their country and put on the transatlantic slave trade route in the Middle Passage. There were many ways in which slavery had happened. It happened within Africa before the transatlantic slave trade. It happened in Arab Muslim communities and enslaving Africans as well across the Indian Ocean, as opposed to the transatlantic slave ocean that was the voyage that we here living in America and identifying as African American endured from our history. There were many different ways that slavery existed. There were ways in which it existed before we crossed the Atlantic and were put enslaved while in Africa and put in dungeons and sent out of the door of no return, such that we would never see our presence, would never see our African land that we walked on, that our ancestors walked on again in that framework. So slavery in America is real. It's not a false narrative. It's a real narrative. It's a narrative that has caused us to be where we are. This is a picture of one of the slave dungeons or slave castles, as they're called, as we were then deported, stolen. I don't even want to say deported. We were stolen from the Gold Coast and sent to America. So this historical issue comes together to identify our race, class, and gender, that we had, and through our gender, different experiences. Many times we talk about our gender being Black male and talk about how hard enslavement was for Black males. And it was. I would never deny that. But enslavement was experienced different for Black females. And little of that is heard. And so we want to delve into our message today a little about the way in which Black females, the intersection of our race and our class as being slaves, our caste as being enslaved, and being Black women, and what that meant for us. We want to look at that issue of how power and privilege was there for white individuals, but was stolen away, and we were marginalized for Black enslaved women. We want to look at the medical interventions that were there for white men to gain economic and social status, to gain wealth, from the experimentations that they were doing on our Black bodies, the experience that we had. So it was through these experimentations that medical science has been able to grow. It was through in stealing or leasing Black women who were enslaved and experimenting on them that medical science has been able to progress and to make these white men to have higher economic status and social gains in their lives. But then torture was at the mindset for Black enslaved women and their ancestors. And so it is that mindset that continues in our medical science. This is the root of what has happened to us. It's, we want to be clear that this is for social gain, this whole medical science, this whole way in which it has continued and created disadvantagements for Black women today has also created social and economic gains for the medical field and for people in that. We want to, recognize that in 1662 in Virginia, there were laws that said that the children of enslaved women would have their status. So it basically ruled that all women, really, it was talking about, but directly as far as chattel slavery, that your children would have the same status that the mother would have. So that meant that if a Black enslaved woman had a child, then that child would be enslaved also. But, we have to recognize that white women bore children of Black men, free and enslaved Black men. And most times that was consensual, bore their children, but they could not keep their children. Those children were not recognized as having the status of their white mother. Those children were taken from them and given and enslaved in the Black community almost 100% of the time. They were given away and raised by other enslaved women or they were murdered and not allowed to survive because they would bring disgrace upon that white woman that bore that biracial child. So again, this issue of power and privilege, and who has power, who has privilege, who has control over our bodies, and who does not. And there is a narrative that had to be created around Black women's bodies. And this narrative provided the foundation to make it okay to do the harmful, painful, degrading, words won't come out today, the harmful and painful acts of minimizing us, degrading us, okay? And some of those narratives that came out, and you may have others that you'd like to add, and if you would, put them in the chat. But it was thought that Black people do not experience pain because they have thicker skin. It was thought that Black women's bodies were built to bear children better than white women, and that Black women could endure hard labor working in the fields and plantations. And Black women are promiscuous, they're loose, they're over-sexualized, and they're always looking to have sex. That you can't rape a Black woman because she is a willing participant in giving of her body because of the way that she sees sex being very much connected to who she is. That Black women are angry, mean, aggressive, and violent. And that these narratives were created for the purpose of oppressing Black women, of using their bodies, of continuing to ensure the wealth and control of the wealth of white men and white communities over as they control the bodies of Black women. We see this in the continuation of slavery that has happened. Women being forced to bear children, forced to have sex, being raped, because I want to name it what it is. Women who were raped by it could be raped by any white man, and there could be no consequences of it. But women who were also then put with Black men and told that they had to bear their children because bearing their children brought white men and plantation owners more wealth. We know that in 1845, 17-year-old enslaved Anarcha was in child labor for 72 hours when Dr. J. Marion Sims was called to assist her. Now, he wasn't called to assist her because she was in pain and that the labor was hard and she needed relief. She was called to have assistance by Dr. Sims because had that child died, then it would have been a financial cost to the plantation owner. And so, we have to keep that perspective in mind. Dr. Sims came to assist her, but he came to assist her to ensure the continuation of wealth for the plantation owner. As he was giving treatment to Anarcha, he discovered that Anarcha had an incurable viscovaginal fistulate, which means that she had a medical problem that came from the fact that she was in labor for so many hours, and that this was something that happened after going through intense, long labor. This is why we should not be allowing women, any women, to stay in labor for unreasonable amount of time, because this fistula could be created as a result of that. Shortly after treatment for an ARCA, because there was no cure for it, all he could do was deliver her child, which he did, was able to deliver her child, but it did not cure the vaginal fistula that she had. And shortly after that, Betsy and Lucy, two other enslaved women about the same age, 17 to 18 years old, were sent to Dr. Sims for the same condition. Dr. Sims experimented on them and other enslaved Black women from 1945 through 1849. There were a total of about, I would say, 12, almost 12 women that he experimented on. However, Anarcha, Lucy, and Betsy, for some reason, were the only names that he listed in his journals. Those were the only names. And so I say with you to join me in calling out their names. Anarcha, join with me in calling out Betsy. Join with me in calling out Lucy, for honoring us with the gift of their life and the trauma that they experienced during their enslavement. I see them as part of my ancestors, whether they have blood lineage or not. They are part of the women who allowed me to be here where I am, who allowed me, through their gift of trauma and pain that they had to endure, allowed us to know more about the surgeries that some of us have had to endure, about the pain and suffering that we've had to endure through childbirth, whether necessary or unnecessary. So it is by fact of, understanding this fistula, because it did not end with slavery. Fistulas still exist. And a vaginal fistula is an abnormal opening between the vaginal and other nearby organs in the pelvis, including the bladder and the rectum. And so these openings cause this way in which fecal matter can be leaked into the vagina. It causes this discharge that can be had from the vagina or for the uranus. It causes damage to the kidneys and infections. It causes other irritations and also pain. There are many different types of fistulas, but the one particular that Dr. Sims was identifying and working on was this vesicate covaginal fistula, the one that he was working on. But there were many different kinds of fistulas. There still are different kinds. And some of the symptoms that we see, including the ones that I named, but also this odor that can be seen, vomiting, diarrhea, weight loss, fever, and other types of symptoms that can be experienced. The one I really want to highlight also is this abdominal pain. And all of these things then made the women, enslaved women who were suffering these symptoms, being seen as outcasts in their community. They were outcasts from the populations of the white population, but also from their enslaved population, because they had this odor, because they could not work. They could not contribute to the work that should be done in the fields. And therefore, this was causing this plantation owner money, causing them not to be able to possibly bear additional children. And so that's the reason that Dr. Sims was working on this issue. this financial gain that could be lost. This is an illustration of when we talk about the fistula, then we talk about these openings, these holes that can occur in the rectum, or the holes that could occur in the bladder. And those holes then leak substance into the vagina and therefore create all of the symptoms that we described. There are many risk factors that are involved for vaginal fistulars, childbirth, especially prolonged and obstructed childbirth. So as we saw, and Erica had 72 hours that she was in labor. There are additional things that could happen like infections or Crohn's disease or complications. Other risk factors can be complications from vaginal surgery. Today in our world, we know that cancer and radiation treatment can also cause these fistulars. They can be caused by pelvic injury, or retained foreign material, which is a vaginal pleurisy, which is a device that's inserted into your vagina to help with prolapse, vaginal prolapse, to stop your uterus from prolapsing. And this metal component is put into the vagina in order to secure the positioning of your uterus. Well, in doing that, then if it's left too long, it can also cause then this whole issue of the fistula. And that, it can be had by pain that's being suffered during sex and swelling and irritation and repeated infections. All of these things are caused by or are risk factors for fistulars that women experience. Dr. James Marion Sims was doing these surgeries in Alabama, in Montgomery, Alabama. He had a clinic in in Montgomery, Alabama. And he performed these experimental surgeries on these enslaved women, the 12 that I named, and he performed them, but he never documented his evidence of these procedures. He would write up papers and he would talk about how successful he was after all of his experimentations, how successful he was, but he never documented his procedures. And other doctors came later and said, well, no, there was no evidence that he was successful, that he was claiming success. He was getting the acclaims and the notoriety of his success, but there was never any evidence that was publicized, that was put into journals, professional journals during those experiments. He eventually was, as he was doing the experiments, he was abandoned by other medical professionals that helped him. And because he was abandoned by them, he had to perform them on his own and even had to force his patients, other women who he was experimenting on, to assist him in these experiments. And so he basically leased Black enslaved women to do these medical procedures. He did not request their permission. These experimentations were done on young Black enslaved women. He operated without any anesthesia. And people will say, well, it didn't exist then. No, it didn't. And so again, it goes to the inhumanity of providing these surgeries, these painful surgeries. Women had to be tied down. They had to be held down so that they would not move, and their naked bodies were restrained in front of all of these other white doctors that came to gawk at this experiment, to see what was going on. They never were given any dignity as he performed these surgeries. He forced the cooperation and assistance of those people who he was operating on to help him. And so Anarcha, Betsy, and Lucy were forced into the medical field. And while they were forced, they were also there because they wanted to help each other. because of their own humanity for one another. So they learn all of these strategies. They had to learn all of the ways in which this doctor, this butcher, he's called the father of gynecology, but he's also known for his butchery in the work that he did, that they had to be there for their sisters as they were going through this process. They had to be there on the table and hold them down, hold each other down. They had to be there when they were released from the table and they were once again together to help treat them, to help nurture them, to help them to be able to heal from the painful events that they were going through. I showed that picture of Dr. Sims, and there are no pictures of Anarcha, Lucy, and Betsy, but we do have artwork that comes to us in the form of this picture that was created by an artist in a Harvard University exhibit. This particular one was created by Jules Arthur as one of the things that was posted in her rendition of what perhaps Anarcha, Betsy, and Lucy look like. We don't know what they look like, but I like the way in which they're presented as being very distinguished, as being women that we can perhaps see and visualize and create a narrative around who they were, about how wonderful they were, about how they took their pain and suffering and had to reframe it to become nurses, to become healthcare workers, to become givers of humanity as they worked alongside of this horrible butcher in that field. There's also another artwork that was done to honor Anarcha, Betsy, and Lucy, and this was done by an artist whose name is Michelle Browder. Her artwork is in Montgomery, Alabama. And so as I attended the conference a couple of weeks ago, we were able to personally see these statues that Michelle Browder created, this phenomenal artwork to honor the mothers of gynecology as Anarcha, Betsy, and Lucy have been claimed, and also to honor the other 12 women who were operated on and whose name we do not know. I'm going to pause here for a moment to see my time. How much time do I have left? If I could get someone from Isuroon.
Yes, 10 minutes, including questions.
Including questions. Okay, thank you very much. So I'm not going to show a video, but here are two videos that I'm sure you would find interesting that will give you more in-depth information about the mothers of gynecology. So Anarcha, Betsy, and Lucy, what we want to remember about them is that they became skilled medical practitioners, but were never recognized. They were returned to their enslavers after 5 years. Dr. Sims proclaimed that he found the cure. As I said, it is not documented that he did that. In fact, after all the Anarcha had 30 medical procedures before he proclaimed that he had found the cure, which he had not, that we know now. But they returned to their communities and were able to go back to their communities with nursing skills, to their enslaved communities with nursing skills to help continue or to practice the support and uplift of enslaved individuals that they lived with. And they were separated. I would think that also deserves to be noted, that they did not go back to one community where they could continue to support one another. They were separated and put back on the plantations that they came from. So Michelle Browder in her Montgomery, Alabama museum has uplifted all of the work of these three women and others. And, you know, this is a portrayal of how Dr. Sims had the women, the enslaved women, on display with clothes on when he did not even allow them to bear those clothes. And then Michelle's rendition of that same thing, because Michelle is putting Dr. Sims' work on notice, on who he was and what he did and how he butchered these women, these enslaved women, for his own financial and personal gain. And so Michelle has created this other artwork that she displays at her museum as well. And Michelle, well, one of the other things I want to say is that Michelle, in creating this in her museum, has done a lot of work. She also has a mobile birthing unit where she assists women in giving birth. She and her team of midwives assist women in giving birth. We know that she also was able to purchase the original hospital that Dr. Marion Sims operated in, out of, in Montgomery. She was able to purchase that original building, and right now is renovating that building to create a home, a birthing center and location for other Black women today, transitioning that. So we know that addressing maternal health is not just, and morbidity is not just an issue of the past, it's an issue for today that we have to continue to look at. We know that disproportionately Black women are impacted by what has happened, and, you know, continue with the risk of those things because of how our birthing has contributed to our ability to give birth, and in an unhealthy way contributes to our ill health in disproportionate manner. And so our living in poverty continues to make it where we don't have the necessary treatments, medical treatments that we should. But we know that all of those things come from the systemic way that we were marginalized, that we were degraded, the systemic way and the mindset that comes out of the enslavement of Black women. And today, what we want to do is to see, how do we move out of looking at those social determinants of health? So when we talk about health determinants, we have to combine those social determinants. What was the impact on slavery? What was the impact on structural racism? What is the impact on the continuation of those practices through Jim Crow, the GI Bill, the redlining, the mass incarceration, and the 13th Amendment that continued slavery as long, you know, as long it was to the benefit through incarceration, meaning that if you were incarcerated, you have no rights of freedom. And therefore, the 13th Amendment needed to allowed for the continuation of that slavery. So those things, and then we need to look at the social determinants today in order for us to ensure the health and well-being of women and birthing people. We need to be able to make sure that there's food stability, that there's education, income, that our neighborhood demographics need to be looked at, and see how those neighborhood demographics impact our ability to have safe water, how it impacts our ability to have food and grocery stores in our community. We need to build the environment around us to make sure that we're able to do those things, looking for safety, looking for housing, looking for access to care and rates of incarceration. We need to have a lens that looks at social determinants and the impact of social determinants on maternal and infant mortality in order for us to increase, because those are the things that will either lead to increasing maternal and infant mortality or decreasing maternal and infant mortality. We have to do what we can to provide that framework to decrease infant mortality. Okay. And we also have to look at how we as individuals and what our relationships are and how our community impacts how our relationships and our community and society impact the individual at that local level. Okay. So I'm going to end there because I do want to try to have a couple of minutes for questions if you have them. But, thank you very much for participating and listening to as I stop sharing. All right.
Yes, please submit your questions in the Q&A box. Thank you so much, Miss Umi. Your session is very inspiring. And thank you for shining a light on the untold stories of these women. Despite enduring unimaginable hardships, they more than contributed to the advancements in modern gynecology that we benefit from today. So in a way, thank you for creating space and educating us.
Thank you so much.
Please, yes, we'll just wait for questions to trickle in, but I have one. I'll just start off from
Sure.
my end. I guess you could just go more into detail on how we can incorporate their stories in terms of thinking about education curricula, inspiring future generations of women in science, medicine, gynecology. How can we incorporate their stories?
Oh, that's very good. I'm glad you shared that. I think because one, educationally, we do not even hear basic stories about enslavement, basic stories about the contributions that Black people have to the building of our great country, but on whose backs? And so when we say, let's look at America and how great it is, we have to look at what the cost was to get America to be great. And we don't do that. And so I think that as I have found out more about Anarcha, Lucy, and Betsy, I integrate their stories into the realities of sexual assault. I integrate their stories into the realities of medical health care. I, want to integrate their stories into this intersectionality of women. I want the story to be told about the contributions that women are making, and they are making those. One of the interesting things that happened at the conference, Mothers of Gynecology, that happened this year, is that they had other professionals come to talk about the mothers of medical science, the roles that they played. They had other women to come up and talk about the role of Black women and Black in dealing with medicine, but Black women in dealing with research, the contributions that were made there. And so starting with this story of Anarcha and this enslavement, but then moving on to show the contributions that other Black women are making in our strides today. So yeah, I think sharing it with our family members, that's that whole thing about the social issues. How do you, when you're sitting down at the table and having conversations with your children, how do you integrate the story about who they are and on whose backs we stand and our ancestors as we do our have our libations, or even as we have our ways in which we express gratitude to our ancestors, and putting their names on the table, speaking their names, calling their names. I think we look at that in our way that we operate today. Yeah.
Definitely. Their stories are definitely inspiring and empowering, and it grounds us just to hear that. So thank you for creating space and sharing your wisdom, Umi. I believe there are no further questions, so we are going to move to our next presenter. Thank you, Umi.
Very good. Thank you so much for inviting me. I wish you a good day.
Thank
Peace.
you. Yes, so as we continue to explore the vital issues surrounding maternal health and the empowerment of women, we want to take a moment and shine a light on Isuroon's own doula program. Our doula program is headed by doula Ebony. As a dedicated doula at Isuroon, she plays a crucial role in providing compassionate care and support to mothers during one of the most transformative times of their lives. I always say, I wish I had a doula during my birth. They're just amazing. And we just want to take a moment to shine a light on the amazing work Ebony does. Welcome, Ebony.
Hey, thank you. Hi, Najma. Hi, everyone. Thank you so much for, I guess, attending this beautiful event and shedding light, like Najma said, on how beautiful women are in our bodies and acknowledging and recognizing that we create and that we are amazing beings. So I really appreciate it. Yeah, so again, my name is Ebony. For those of you who don't know, I am the maternal and child healthcare coordinator here at Isuroon. I'm also a childbirth educator, a lactation support specialist, and I also hold my master's degree in social work. So again, thank you all for being here. I'm here to talk about our doula services. We just recently started launching this program, and I'm so excited and ecstatic about it. We are now seeing about 10 clients and are getting more referrals in every day, and I love it. So first, I wanted to address what a doula is for those who might not know what a doula does and what they represent in our community. And then I also want to talk about the services that we provide, and I will explain how you can get connected within our program. I think it was a beautiful segue from Ms. Umi's presentation to talk about addressing the morbidity and mortality rates within maternal and infants. And I think that it's a very crucial thing to talk about as of now. It is definitely a crisis in our communities that women are not, they're not looked at in a way that they should be. And I think being a doula and supporting women during this crucial time of their life is very important when they are pregnant, during labor and delivery and also postpartum. So as a doula is a trained professional. We're not medical professionals or medical providers. So we are encompassed within a team. So we work with midwives and OBGYNs and support our clients throughout their pregnancy, during labor and delivery and also postpartum. So each doula, they can serve under different roles. So not all doulas are specialized within supporting clients throughout the whole course of their pregnancy, but some doulas can support women just throughout pregnancy. Some can do labor and delivery, and some can be postpartum, as well as helping throughout miscarriage and death as well. So our agency, we actually work with women throughout all of these areas. Our doulas are trained and certified to support women throughout the whole course of their pregnancy. Yes, so when you are referred to our agency, if you are referred or if you refer yourself, you would go through an intake process, which I'll show you at the end of this, through our website, where you are asked a various of questions so that we can see how we can best support you throughout your pregnancy. And then you will receive a phone call from me, and we will do an intake form and get you in and matched with a doula so that you can be supported throughout the remainder of your pregnancy, throughout labor and delivery and postpartum. So we support also throughout pregnancy. We help with emotional, physical, educational support, and we also advocate for our women, depending upon what they, how, to the extent of which they want us to advocate for them. We can attend doctor's visits. We can attend, go with our doulas to maybe the gym and support them on different exercise routines that they can get into to help them throughout their pregnancy. With these skills, a doula's purpose is to help women have a safe, memorable, and empowering birthing experience. So to name a few, Doulas can help with tension release, relaxation, techniques, prenatal massage. We can help create a birth plan. We can assist you with breastfeeding, assist you with unmedicated births. We also want to encourage vaginal births, but we also can help with any experience, any birthing experience that you do go through. So no matter what it is, whether it's vaginal C-section, medicated, unmedicated, induced, etc. We can help with stress reduction. We can also assist fathers and family members on ways to support the mom and throughout her pregnancy. So that's one benefit of having a doula, that we can help others within the community and within family support this client as well. Again, we are not medical providers, so we cannot give medical information or any medical interventions to our clients. Sorry, I'm looking at my notes too, just to make sure that I'm addressing all things. So with our services, we provide education around pregnancy, labor and delivery, newborn care, mental health, comfort measures and mechanisms, as well as advocacy, like mentioned before. We are on call like the last 2 weeks of a mother's pregnancy. So anything that might be going on throughout your pregnancy, if you need to call us, we are there to support you. We also help with postpartum care. So the process is to submit a referral or talk to me or any of our other doulas in our agency. We'll go through again that intake form, and then you will be matched with the doula, and then you can come up with a care plan with your doula on what ways you would like to be supported within this relationship. And then, yeah, so I do want to share my screen here to show you. So with the help of John and creating these beautiful pictures, we have a brochure that I'm looking to get out into the community really soon here. So this is a representation of what our program is. And I know it's kind of confusing, but the brochure starts where it says the doula program. And then throughout, we just kind of explain what it is that we offer. These are ways that you can connect with us. Again, me being the maternal child health care coordinator, you can contact us through the office, or you can contact me directly through the number that is provided here, as well as through my email address. And you can also scan this code to go directly to the intake form on our website. And then again, this is just more information pertaining to what our services offer, or yeah, the services that we offer at Isuroon. Let me see one thing. I'll share. And then I'm going to show our website as to how you can get to this referral form. And then I'm gonna hurry up because I know I don't have too much more time left, but let me see. So again here, this is how you would get to our website. You would go to isuroon.org, and under programs and services, you'll go here to women's health and wellness, and then it'll bring you here to this part of the website. And under this section, you would click doula program. And then again, this will show you what we offer and how we can support our clients. And if you just scroll down to the bottom here, you can click the intake form, and this is where you would fill out basic information pertaining to the woman that you are referring, or if you are the mama that is wanting to receive doula services, you will just put here the information so that we can contact you and go through an initial intake. And that is it from me. Thank you for listening.
Thank you, Ebony. Thank you. Please, again, put your questions in the chat. Honestly, I always say I really wish I had a doula during my contractions just to like get me through the process. But we are privileged to offer doula services for our marginalized community here at Isuroon. Take advantage of it. It's here for you. And thank you, Ebony. Are there any questions currently? I'm not seeing any, but please go to our website, do the intake. It doesn't hurt to ask questions. Ebony's very responsive, very sweet. And we're so excited to have you. So just to keep things moving.
Thank you. Thank you.
Yes, we want to end on time. Do we have Fortune on? We want to shine a light on our contributing members. Ray, please let me know if Fortune is on. If not, let me see. That's okay. We can just go ahead and take much needed intermission. Should we do 10 minutes? Yes. Let's have a 10-minute intermission break. Please bring up the break slide. Feel free to stretch your legs, refresh yourself with a beverage. We will reconvene in 10 minutes at 11:44 for our next presenters. Thank you for your attention and participation thus far. We're getting there. See you guys in 10 minutes. Okay. Welcome back, everyone. Thank you, thank you. Oh, can we go to the awards slide real quick? I just want to take time for that. Yes, welcome back everyone to our virtual conference. I hope you've had a relaxing and rejuvenating 10-minute break. Time is flying fast, but we are thrilled to continue our session. But before that, as you know, we are celebrating International Women's Day, and at Isuroon, we want to honor the trailblazers who ignite progress within our community, like Representative Hodan Hassan. We love her. We love her. Thank you. We want to recognize the individuals who not only stand with Isuroon, but also push the boundaries of advocacy and support, celebrating our change makers. We want to honor these remarkable leaders with the Isuroon Catalyst for Change Award for their extraordinary contributions and unwavering support. Thank you, Senator Sandra L. Papas. Thank you, Senator Omar Fattah and Representative Fooley. We just want to take the time to thank you for being a catalyst for a better tomorrow and for the marginalized community we serve here at Isuroon. Thank you for your relentless pursuit of justice and sparking dynamic progress. Thank you. Just to be punctual on time, we want to move to our next presenters. Let's give a warm virtual welcome, round of applause to Hallie. I'm so sorry if I'm mispronouncing your name, and Aaron Shen. They are from the University of Minnesota's Medical School. They bring their knowledge and They bring their knowledge and expertise to today's webinar. Thank you for joining us, and let's continue our informative session.
Awesome.
Welcome.
Thank you so much for having us. I am going to go ahead and share my screen if that's okay, Najma, for our slides. Great. Thank you. So thank you for that really kind introduction. Again, my name is Haley Brownbott. I'm a medical student at the University of Minnesota Medical School.
Hi, everybody. Happy to be here. My name is Erin. I'm also a medical student at the University of Minnesota's Medical School.
So before we got started, we wanted to give a couple of disclaimers about this work. We're here in part because of our work with Dr. J. Meg Carbia, who is an assistant professor at the Minnesota School of Public Health. And we've been working with her on racial disparities in maternal and child health. And that's how we kind of got connected with Isuroon and today's event. We do want it to be a co-learning space, so we'd like as much participation from you all as we can get. So using the chat function and the Q&A, we're going to have a couple of discussion questions that we'd love to have everyone participate in. And obviously, Erin and I are not Black women. And so we want to be clear that we are not speaking on behalf of a community that we don't come from. So we're here as much to learn from you all as hopefully we are able to share with you. So we wanted to start off with something really basic. So what exactly is maternal depression? Please share like a word or two in the chat that comes to mind when you hear about maternal depression.
Yes, and like Haley was saying, we kind of had this in mind as much of a discussion as possible. So we'll kind of be monitoring the chat and we'll try and read out loud everyone's responses so we can make this as interactive as possible.
I can start us off with a couple of them. So I think shame is sometimes a word that comes up. Fear, loneliness are things that we hear about a lot. And we're seeing some of those populate as well. For a formal, more clinical definition, stress and unmet needs. Ebony, thank you, 100%. And I think sometimes a lot of confusion. I think the postpartum time can be really stressful for any new parent. And it's hard to be able to identify what is normal, what isn't normal, and how do you determine what does or does not work. Okay. Okay, as an FYI, it seems like the chat function isn't working. So please put any of your thoughts in the Q&A, even if they're not actual questions. And we will go through and identify what is chat kind of input and what is actual questions. So thank you for flagging that.
All right, so just going through kind of what we had talked about in our discussion about maternal depression, but maternal depression is defined as a range of conditions that can affect women during pregnancy and up to 1 year postpartum. So quite a bit of time after giving birth into the first year of being a mother. It encompasses a spectrum of conditions that can include prenatal depression, the baby blues, postpartum depression, and also postpartum psychosis. Just to highlight some of the key, more clinical symptoms of maternal depression, these can include crying and weepiness, sadness, irritability, exaggerated sense of empathy, anxiety, mood ups and downs, feeling overwhelmed with a sense of responsibility of being a new parent and kind of the weight of societal roles and everything like that. Insomnia, which includes fatigue and exhaustion, as well as frustration. And so just a little bit more background about statistics of maternal depression. Up to 1 in 5 women in the United States will experience maternal depression. So this is a very commonly experienced phenomenon amongst people who give birth. Specifically, up to 44% of all Black mothers will experience maternal depression, which is a key health disparity. And up to half of these women will not seek or receive appropriate treatment. So kind of thinking about these statistics, a question for the group, and we can use the Q&A function, is what is the cause of increased maternal depression amongst Black mothers that you all can think of?
One important thing that Erin noted in talking about this particular health disparity and saying that, we are saying that 20% of all women in the United States will get maternal depression, but almost half of all Black mothers will. Something we want to call out that maybe is difficult to be specific about is that race itself is not a risk factor, right? I think that's something that has gotten lost in a lot of public health discussions and a lot of our own understanding of what health disparities are caused by. It's racism that leads to that disparity in outcomes or disparity in experiences. And so something we want to emphasize through this whole presentation is not that there's something specific to Black mothers that they are experiencing or being, exposed to necessarily that's inherent to them, but it is a societal structure. Someone mentioned hormones and changes could be one potential cause. That's a good one. Another one would be societal expectations. So there might be people who have increased expectations of them in the postpartum period, whether that is through work expectations, family responsibilities, potentially not having other support systems in place. Ebony mentions a couple of these. Traumatic pregnancy experiences is a huge one. Something that's been talked about today already, labor and delivery, postpartum, they're all different areas in which a mother might experience trauma, and even in the pregnancy itself, right? And so just because you've gone through the delivery and have a child now doesn't mean that you've resolved all of that trauma or that you've had the ability to have the resources and structures in which to work within. So those are great thoughts. Thank you for sharing.
Yes, and Haley's point about how racism is the cause for this disparity in experiences kind of ties into our next point, which is a question for the group relating to how cultural and racial identities impact maternal depression. There's a question for the group. Can throw any thoughts into the chat, and then we'll discuss a little bit more about this in a second.
So some ideas to kind of get the ball rolling would be, what do we even understand by why culture and race might impact maternal depression or any other health experience? A lot of us might come from communities where even talking about mental health is difficult or not taught or not accepted. And so to A, be able to identify that you're experiencing maternal depression, and then B, let alone share about it and seek help for it, can be really, really difficult. So that's something that I think is unique to a lot of cultural groups. It can even be something as obvious as not sharing the language of the community that you're in. Many folks coming from immigrant communities, refugee communities might come to the US and give birth, but then not have the access to receive the care that they might want. Yep, someone mentioned that some cultures maternal depression is taboo and unnoticed. That's a huge one. And it can make a lot of folks who are experiencing it also feel shame in that process. And important to be able to identify those things, right? So one thing that we were thinking about in our research, because we're coming from a clinical and research background, is what does the literature say, right? Not every experience can be codified in literature, but there is something to be said for what have we seen over many, many years of research that gives us some sort of explanation as to why there is so much of a higher rate of maternal depression amongst Black mothers. And we thought that this quote was really interesting and really kind of encompasses what we were talking about. So to read from it briefly, the accumulative stress of living in a racialized society with intersecting systems of oppression. So that includes gendered racism, ageism, sexual identity, that negatively influence their emotional well-being, mental health, and consequently their maternal functioning abilities. So this is the explanation that this paper found for why postpartum depression amongst Black mothers might be higher. And they're talking about maternal functioning abilities, which is something that they, in the paper, defined as, your autonomy, your emotional and social support, your ability to identify yourself as a person, but also as a mother, and your relationship with your child as time goes on. All of those can be impacted by these intersecting systems of oppression that we talked about. And it can be things that are as basic as, do you have access to transportation to get to your postpartum appointments? Do you have the adequate insurance coverage to be able to have access to healthcare? Do you have systems of support at home to be able to rest and take some time off? And all of those can be really, really difficult for different mothers to navigate.
And so going off of what Haley talked about in talking about the intersecting areas of oppression that can be seen, what does this look like in the lives of women that we know? So do we have any examples of people that we know in our personal lives or stories that we can hear in our work that reflect kind of these intersecting systems of oppression and some of the challenges that might be faced by specifically Black mothers?
I can share one example and then maybe we can have some others in the chat. When I was in graduate school, one of my co-classmates was a young Black mother, and she was doing this really difficult thing of her and her 3-year-old daughter had moved together and she was working really hard to get her master's degree. And the state insurance that she was on required her to prove that every month she was going to a job fair and actively seeking a job, even though she had shown the state that she was a student, a full-time student. And it was just one more hoop and obstacle that she had to jump through to get dressed up, go to a job fair, fill out all this paperwork and prove, hey, I'm looking for this job that I don't actually need because I'm in school right now, in order to be able to get the insurance coverage that she and her daughter needed to live healthy, full, fulfilling lives. And it's one example of a type of system of oppression that many people might face.
Yes, and we have something from one of the participants, which is a personal story about someone's cousin who had postpartum depression and she could barely eat and connect with her baby. And this is just another example of struggles that might be faced by women. And also there's a lot of structural issues that come into play. Do they have support in terms of community systems to get food, or like maybe larger federal support that can help support people during this difficult time? So kind of tying into our next slide, this quote that we shared from this paper highlighted the impacts of intersectionality, basically the intersecting systems of oppression that exist in our society, and the different types of discrimination that can be faced, and kind of the cumulative effect of them. So there's discrimination in terms of gender, specific gender roles that women face, and kind of the burden that comes along with that. Race, we've kind of talked about how racism is the biggest factor here. Racism faced in either interpersonal ways, structural ways, and also class. Can people afford to buy food for their baby. It's really, really expensive to have a child. Not only the delivery costs of the hospital fees, but also buying formula is very expensive. There's all these child wellness visits, postpartum visits. It can be very expensive. So all of these factors kind of tie into cumulative stress, which is a big contributor to the development of maternal depression. This paper that we cited earlier also talks about a strong ethnic, racial, and cultural identity as a protective factor against maternal mortality. So having a strong identity within your community, having strong community support, and also feeling tied to yourself and kind of where you stand in society can be a strong protective factor against maternal depression. Some other papers also highlighted the importance of community. I kind of touched on this earlier, but having a level of social support can be huge in preventing and also treating maternal depression. And this support can be not only just from like a partner or a co-parent, but also family members, friends, mentors, older community members. That can be a huge benefit in both prevention and treatment of maternal depression.
And this is something Erin and I both talk about a lot in our training right now, because I think part of the reason we were invited to give this talk is to give a clinical perspective on maternal depression. And I think the fact that it's underdiagnosed in a lot of Black and underrepresented communities is really, really important. And a part of that comes from not knowing how to best identify what is the key risk factors for one particular person, aside from quote unquote race or background, and B, to be able to give meaningful forms of intervention that are helpful. So like Erin said, because ethnic identity can be so protective, how can we as future physicians help our patients identify what are the things that already exist in their life that can help them to navigate this understandably difficult time? And so through decades of research, we're not even close to the first ones who have been invested in this work. There have been 5 key pathways that have kind of been identified as key ways in which not only can maternal depression be better identified and treated, but also prevented. And so we'll kind of go through each of these one by one and snowball some ideas of what they might look like. But all of you, I would invite you to think about, okay, which one of these really speaks to me and might speak to the community I come from to be really helpful. So the first one is something that Erin and I were both chatting about, is educating and training practitioners. As we mentioned on the first slide, defining maternal mortality and maternal depression, all of those signs look really different in different people. And so the people around you might be the ones who can best identify, oh, your behavior has really changed, your attitude has really changed in a way that a practitioner might not. And so training doctors, nurses, NPs, doulas, to be able to ask those questions, you know, do you feel different now than you did 4 weeks ago? What support have you been getting at home? Things like that, so that your doctor, whoever your caretaker is, can help guide you through that process to understand how you've been doing. Another one is investing in Black women mental health workforce. So this is a conversation I think that is much bigger than just the maternal depression arena, but it really speaks to being able to care for your community from that community itself. And those second and third bullet points are kind of all intertwined in understanding that it's not the job of other people to come into the community and tell them how to better care for themselves or how to improve their outcomes. Usually the community itself already has that knowledge, right? Most of us come from long lines of often women who know how to take care of one another. And so being able to use that community knowledge and bring it into something that can benefit even more people can be really, really helpful. And so you have things like Sister Song that exists in Atlanta and other communities that do some of that work in the maternal and child space that can also be then expanded into maternal depression as well. This fourth one I think is really important, valuing, honoring, and investing in community and traditional healing practices. I think that's something that traditional American medicine has been really bad about respecting in previous years, and something that I think we hope to help change the tide on. But there are a lot of people who come from either Indigenous communities, Black communities, immigrant communities who have ways of taking care of mothers in the postpartum period. There are a lot of cultures that send women back to their, paternal home during pregnancy so that they can be better cared for and don't have to worry about taking care of their husbands and the overall family structure. There are others that have certain rules about, what you eat in the postpartum period, or your mom comes and stays with you during the postpartum period, things like that, that we might overlook in Western medicine are things that are really important and can be really healing for a lot of new mothers. And lastly, promoting integrated care and shared decision making. What that ultimately means is that if someone is your doctor, that doesn't give them the right to tell you what to do. They might have certain knowledge that you don't, but you also have knowledge about yourself and your body and your mind that your practitioner doesn't. So being able to create a teamwork framework about what's going wrong, how can you fix it, what's working, what's not working, and kind of treating your health as a community undertaking and something that you do together as a team can be really, really healing for a lot of people.
All right, and just to kind of wrap up our discussion, based on what we talked about and also kind of what people have thrown in the chat, how can we better discuss maternal depression in our communities, and what can your community use more or less of in regards of mental health support?
Sophia mentioned we could use more doctors offering resources, 100%. I think that's an area in which, you know, there's a lot of improvement to be made, both in providing resources in general, but also providing resources that are culturally competent and appropriate for different patients.
Yeah, and I think as people who are training to go into the medical field, there can be often a lack in, not a lack in knowledge, but kind of a gap between the OB period when you're pregnant and also the postpartum period. So you kind of transition from an OB patient into just a regular patient again. And sometimes there can be a lot of things that fall in the cracks, and a big discussion can be maternal depression. We also have some in the chat that says, as a doula, like Haley mentioned, I will look towards creating a questionnaire asking moms how they're feeling after giving birth. Training our doulas on ways to address this is very important. And yes, that's definitely true. Kind of expanding the conversation about maternal depression in practitioners of all different types, I think, is very important.
One other thing that Erin mentioned that to highlight is even just discussing maternal depression. I think there have been celebrities in a lot of different countries who've come forward to talk about depression in a lot of different aspects of their lives. But I think maternal depression can also be one of those things that we work as a community to take away some of the stigma from. Because I think that can be one of the scariest parts for folks, is feeling that they're alone or that no one else has ever experienced anything like this. And so I think that's something that a lot of us who are interested in this work are also really invested in, to, you know, take away some of the confusion and loneliness in it, and to understand that there's a whole community of people who are experiencing similar things to you and who can help you in that process.
Yeah, definitely. I think especially as a new mother, it can sometimes feel like a personal or moral failing that you're experiencing these symptoms and you can't, you know, give to your child and be there as much as you'd like to be. So I think reducing the stigma around these conversations and also highlighting to new moms that, you know, this is not a personal failing of your like part on any way. It's just kind of, you know, a chemical change in your body, and just opening discussion to make sure that people understand that it's not, you know, your fault, and also kind of reducing the societal stigma that new moms face, and kind of like handling everything in their lives and kind of showing that it's okay to seek out help. We also have another comment in the chat that says, Isuroon works in the community to enhance communication on this topic. What do you think the medical community needs to do to facilitate communication with a diverse population? Yeah.
I think that's a really, really good question. And I think, honestly, one of the most important ways that can be done is by having more diverse people in the medical field. I think there's really a lot of lived experience that comes with being a person of color, a woman of color, someone from an immigrant background who steps into the medical field. And I think University of Minnesota Medical School, we are lucky to have a lot of classmates who come from really diverse backgrounds. And I think that's a hugely important part of medical care. I think there's something really healing and safe about getting care from someone who looks like you, or who prays like you, or who's lived the way you have. So I think that's one really important thing. I think the other thing is to lead from a place of curiosity. I think there are a lot of patients that me and Erin might have in the future that we don't have a lot of shared experiences with, but who we can be curious towards and invite them into conversations to better understand where they're coming from, what does and doesn't make sense for them in the postpartum era or during their pregnancies or at any other point, and to create a shared learning experience between us and our patients, as opposed to the kind of paternalistic approach that medicine kind of often has, where your doctor is supposed to know what's best for you and tells you what to do instead of inviting you, to work together to make your health a little bit better.
Yeah, that's pretty much exactly what I was thinking. I think it's really important to work like with your patients and where they're coming from, and kind of we talked a little bit about shared decision making, but basically there is a lot of movement and work that's done from communities, and instead of kind of working and proving that your like the medical approach is better, but kind of supporting the community work that's ongoing. And we also have a comment in the chat that said it'd be interesting to know how different cultures experience and deal with postpartum mood disorders. I think this is a very interesting point. I can talk a little bit about kind of my background, but in a lot of like Eastern Asian culture, there is a postpartum period of 100 days where you have some rituals that you do, and you basically are with either your mom or your mother-in-law. And I think this is a huge part of kind of caring for the mother in the postpartum period, but also there's a huge amount of familial support that goes into raising a child. And I think that is sometimes a little different in specifically Western culture, where the mom seems more solely responsible for the health and well-being of their child. But in kind of like my background, the family is super involved, the grandparents are super involved. And I think that can really help spread the work out postpartum. Having a new child is a lot of work, so that can reduce some of the stress and hopefully postpartum mood disorders.
Yeah, I think another big part of that is one of my deep-seated passions in life is talking about neocolonialism in healthcare and in public health work. And I think so much of maternal and child health specifically has really suffered from the impact of neocolonialism. And by that, what I just mean is a lot of countries that either experienced colonialism, experienced wars, who now exist in the US as refugees or immigrants, have been taught that their indigenous practices were not acceptable, or that they were uncivilized, or that they were not advanced enough. And now a lot of Western medicine is kind of rediscovering or discovering for the first time a lot of those practices that many of these communities have been forced to let go of. And I think that exists in Black communities, that exists in Brown communities, exists in Asian communities. And so I think being able to reconnect with some of those more traditional practices, like Erin was saying, can be really, really healing for folks, and can be healing for folks even who are not from those communities originally. I think there's a lot of knowledge we can share amongst ourselves across certain identity lines that can be really protective. But I do think that it's really sad sometimes to see how things that were even in Indigenous American communities that were really, really helpful in terms of how a mother and a new child are treated have been lost over time just because of various influences. And I think something that a lot of folks in at least Western allopathic medicine are trying to grasp a hold of, because it can be so much more protective and helpful than the regimen of drugs and other things that we might be able to offer you. Are there any other questions that we can answer at this time? We've had a lovely time chatting with you all, and thank you for participating. I know it was maybe not what you were all expecting to be put on the spot in our conversation, but we've had a really lovely time.
Yes, thank you, Erin and Haley, for your insightful presentation. I am so hopeful there are future doctors like you in the making. I really am. Thank you. I appreciate your insight on maternal health and advocacy. A question I personally have, and this could be our last question due to timing. How can healthcare providers, and I think you kind of answered this a bit in your presentation, improve screening and early intervention for maternal depression? I just had a baby back in October, and I was just asked one question: how are you feeling? Are you depressed? I was like, no, I don't even know what that term encompasses or entails. It's such a big term. I was like, no. And then my OB just moved on. So any suggestions or any insights would be helpful.
I think I'm sorry that was your experience. First of all, I think that there can be a huge amount of work that can be done to just prevent some of the worst outcomes of maternal depression. And a lot of that can be done in the OB period before giving birth. I know that there is a ton of research being done on kind of survey methods, intervention methods in the pre and postpartum period to kind of prevent maternal depression from developing. But I do agree that this is a huge area of kind of lacking right now, is that there's not a lot of good like pre-intervention methods for this. And I think more people now in the medical community, at least like from my experience personally, aren't talking about maternal depression. And I think that's a huge culture shift from kind of what maybe 30 years ago the culture of OB practice in treating postpartum depression is. But Haley, do you have any thoughts on this?
Yeah, I mean, I think that's right. I think you yourself called out the issue, right? Is like, what does depression mean, right? It can be something different for different people. And so I think maybe what your provider could have done a little bit differently is to just give you some ideas of what that could look like. You know, are you feeling more annoyed? Are you getting upset with people more than you normally would? Are you sleeping a lot? Are you not eating as much? You know, so I think that that is one thing that individual providers can do is, you know, you have a relationship with your patient, you know what they're like at baseline, what's different, you know, what's changed since you've given birth. But to Erin's point, there's no perfect one method, and what might work for me in the postpartum period might not work for someone else. So I think that is one of the challenges, is treating each mother as an individual person, but also trying to find a system that works for as many people as possible. And I don't think that's an easy fix.
It definitely is not. And we're not a monolith. We're so different. Different things work for different people. But yeah, thank you, Erin and Haley. We really appreciate your time and capacity. Thank you for your enriching presentation.
Thank you so much for having us.
Yeah, thank you. It was great to see everybody here.
Now we are moving along, everyone. It is my pleasure to introduce our next speaker, certified nurse midwife Anna Levin from Park Nicollet, with a dedication to providing complete and mindful healthcare to women. Anna's background and experience makes her a valuable asset to our exploration today of maternal and child health. Today, Anna will be sharing her insights on the intersectionality of trauma, reproductive health, and vulvar care. Welcome, Anna. Thank you for being here. Would we be able to spotlight her?
Thank you.
Anna.
Can you guys hear me?
Yes.
Okay.
You can begin screen sharing when you have the choice. Okay.
There we go. And then this is my first time sharing screen and doing all this stuff. So let me just make sure I have it. How do I get just to the full screen?
You will start in the left corner where it says from the beginning. It'll start a slideshow.
Cool. There you
Yeah.
go. Well, welcome everybody. Thank you for spending time doing this. I know everybody's got really busy lives, but I think this is really important. And I want to start off by saying a couple things. I am absolutely not an expert in this. I have actually learned a ton in doing some research just to get some background. My interest really lies, I've been a nurse midwife delivering babies for about 17 years at Park Nicollet, and I just retired and doing mainly gynecologic clinic care. And about 7 or 8 years ago, I started training with one of my physicians on specifically vulvar care. And everyone's always like, oh, what's that? So it's very specific vulvar issues, vulvovaginal issues. So things like recurrent vaginitis, dermatologic issues like lichen sclerosis, Crohn's disease, things like that. They're pretty unique. Nothing I learned about in school, and definitely learned a lot on the job. And what came to mind is there's a wonderful, our governing body is the International Society for the Study of Vulvovaginal Disease. And there's an amazing dermatologist in Milwaukee. She goes by Shola. I'll share her information because I stole a couple of her slides. who really is focusing on dermatology of the vulva is one of her specialties, but dermatology of women with dark skin. And we have a little bit out there, but not a ton, and especially not, I haven't been in school for over 20 years, so I don't know what they're teaching now, but it's definitely not a mainstay in our education. And that's probably one of my biggest concerns, is kind of where's this education? So that's where my specialty comes in. I am not an expert on trauma, and obviously not an expert on women of color, but I do take care of a lot of women of color, and it has become a passion to make sure everybody gets equitable care, but also learning that people come from different places, and that's where the trauma comes in. And it's been fascinating, not because I've been taught, not because it's actually been talked about, but learning and watching women, new immigrants. How do I take care of these women? They have different ways of presenting symptoms, and we're not taught that. We're not guided that in our institutions. I hope that this changes. Trauma-informed care is a pretty big buzzword, and I hope they're incorporating it in mainstay medical care. I know the U of M Med School is doing some. So I only hope that this helps improves people's experiences. So just the agenda, wanted to talk a little bit about trauma and women's healthcare. I think we're all very aware of this. I have to move this so I can see my whole thing. Gynecologic care for women of color, and a call to action. This is something that Fartun and I speak about often. There we go. So one of the, now I can't see my camera, but I was trying to get rid of it so I could see my slides. But this was an amazing paper. I can share my reference page, but it was from the University of Minnesota School of Public Health and the MDH, the Department of Health. And it's called, the paper is called Intersectionality and Trauma-Informed Applications for Maternal and Child Health Research, an Evaluation and Initial Summary of the research that's out there. And I just thought they made amazing points. Can you see, how do I get this out of my way? There we go. So acknowledging the systems that cause harm are obviously our number one in what we're doing today. And so both intersectional and trauma-informed lenses emphasize the need to recognize the ways in which systems and organizations perpetuate harm. And the barriers that we talk about in modern day language really is so interesting to evaluate, where are people coming from? Where is this coming from? Where does this historical trauma come in with modern day trauma, medical care trauma that's very, at least I guess in my world, but very widely written about in journalism. Maternal health care for Black women has been a pretty big thing, and people reading about and becoming aware of is amazing. But it's really uncovering a lot of lack of not only research, lack of teaching, but lack of understanding for the medical community. So as it was amazing to hear Miss Umi Hankins talk about historical trauma. We're not taught this in school. We are not, we don't even discuss this, I think. I don't think I've ever had a conversation about this with any of my physicians or, you know, in a day-to-day work environment. Are we paying homage to our history? The interesting part of the historical trauma is, well, where I'm interested in, is this changing people and how is this affecting current day healthcare? I think the healthcare system, I guess I should speak for myself. I struggle to understand where my patients are coming from. And I take care of a very high immigrant population. We are not taught about where they're coming from and what that trauma was. I had to read about it. And really what I do is ask my patients about it. What was your experience? You just got to this country. Where did you grow up? what was that like? And I think that's where the learning has come from, fortunately and unfortunately, in talking to the patients. But I feel like we should be better prepared, but knowing where the American Black woman is coming from and the distrust that they have in the medical community is pretty apparent when you start learning about that. And then common day things, Serena Williams has been a great voice. This is just one study that we looked at, or I looked at, with basic things in medical care. And it looked at, these are all Black people, women, men, and 2 different age groups. And I'm happy to share these slides so you can read these through. But just basic things like simple complaints that you're taking, or that you're talking about not being taken seriously. I think as we'll talk about, some of it is really rooted in obvious systemic racism, but from what our history has taught us. And so my main interest in how I got involved in the vulvar care is I had a disproportionate amount of women that I was seeing coming in for recurrent vaginitis. So vaginosis and vaginitis can include chronic yeast infections and chronic bacterial vaginosis. And without going into detail of those, they're just very, very bothersome and often life-limiting infections that women experience. And I was astounded at people coming in every single month for the same treatment, and I didn't have anything better to do. So yes, raised hand. I'm not sure what to do with that. Is there something in the chat I should look at?
Patricia, do you want to come off and ask your question?
Come off the PowerPoint?
No, I was talking to the person who raised their hand.
Oh,
I
just saw a hand raised, so I didn't know what that.
And then there's Suado. Suado, do you want to ask your question? Are you able to? Okay, keep going, Anna, and then I'll type the chat here.
Sure.
Thank you. All questions will be coming through the chat.
Oh, sorry.
The Q&A section. Thank you, Anna. Please continue.
Sorry. I definitely don't want to just be talking to you. And as you'll see, this is more for me learning. But I was just going to try to talk about some of the things that I'm seeing in practice. So bacterial vaginosis, yeast infections, very, very common. And it was interesting to start reading about this and see there's a lot of really fascinating essays, writings, research about where this is coming from, and why we see in practice, but in marketing and advertising, why are Black women more likely to be using scented products? And this really came from, well, I think I'm jumping ahead, but let's see. Oops. Nope. Okay. So this really piqued my interest when I started learning about this. I hope many people know about this. It's a pretty common, issue or event that is being talked about, but there's been pretty cool podcasts talking about this. But it's just astounding when I learned about it, that simple thing like Johnson & Johnson baby shower, huge. There's over 100,000 lawsuits against the company for using talc in their products. But an interesting podcast or interview on NPR, it was probably 2 years ago I heard it, and I should have found it for you guys, but was a woman who grew up using baby powder. She said it was a real sign and a sign of cleanliness in the neighborhood. And everybody in her family had used it for decades. And it was taught to use it. You get out of the shower, you use it. And lo and behold, we come to find out that Johnson & Johnson knew about the talc and the asbestos in the talc, and that they might have known that that can cause cancer. And there's a huge lawsuit for in a disproportionate amount of Black women with ovarian cancer. They think of because of this with the mesothelioma. It is because of this, but I think they've settled quite a few of the cases. It's just a mind-boggling phenomenon that is happening because you feel like you should be able to trust products, and they've uncovered more emails saying, you know, they knew that they were directing marketing towards Black families. You know, we know that, like with other examples, like Cool Cigarettes, you know, marketing to kids, marketing to Black neighborhoods and stuff like that. And so that's been really fascinating, that it's just inequity, I guess, or just I don't know what else to call it, but it's just evil. And I know there are things in our system, like just tobacco, right, targeted to everybody, but with them knowing the link to cancer, you would think that we'd be able to trust our system more. So this is just reaffirming for patients and families that are already distrustful of the system. This is just more evidence of why, and good reason to stay. So into what I am more of an expert at, and talking about vulvar health. I would say one of the biggest things we see, and most common things we see, like I said, are the vaginitis and vaginosis. And then the number one kind of dermatologic issue we see is a dermatitis, so irritation. So kind of like eczema, you definitely can have eczema of your vulva, but 9 times out of 10 when we have someone come in, my newest gripe is they say I itch. No one asks exactly where do you itch. They assume it's the vagina, so they swab you. And my take on it in clinic is, where are you actually itching? And 9 times out of 10, it is on the outside, on the labia. And sure, we should rule out for things vaginally, but 9 times out of 10, it's because of the products we're using. We're not taught that. Most of the marketing is scented and perfumed products. You go to a grocery store or a Target or whatever, the aisle is always pads, yet no one knows that main product in their, a main ingredient in their product is called an acolyte, and it's highly irritating. We don't have any long-term data to support that it's causing any sort of cancers or any sort of internal damage, but we know on the outside that it's causing an extreme amount of irritation and dermatitis. And people don't think about it. They've been using their pads. They're the most common pads. Everybody uses them. Not everybody's itching. And no one thinks that that's one of the causes. But it is very interesting, and there is quite a bit of research on bacterial vaginosis rates, which is much higher in African American women. So this is this woman that I just am obsessed with. She's wonderful. She's a dermatologist, really trying to get more highlighting skincare for women with darker skin tones. And it was interesting, this one on the, well, my left, probably your right, was the forensic nurse, and just evaluating somebody that comes in, say, from an assault in the ER, was realizing how symptoms and skin changes present in different skin colors. And we needed training, they needed training to be able to identify this, right? So I thought that was very interesting and pretty basic, that you would think would be basic knowledge. And then, you know, I call her Dr. Shola, is very smart. And some of this is a lot of science, but it's just looking at how different skin cells absorb different materials or present. And that's kind of what we need to learn by trying to diagnose things, is we have to know how things present differently in different skin tones. So this is her. I can send it. I should probably put her picture and her bio up. But she's at, I think, the Veterans Affair, and one of the professors at the med school, but in Milwaukee. And this is our governing body. And I can definitely share that webinar with anyone who's interested. It's pretty fascinating. And I didn't want to include any graphic pictures that we do in our topics here, because I didn't know if that was appropriate here, but I'd be happy to talk about that with anybody. So then just learning about more of this, it's been really interesting. And it's, I think, a pretty big topic, at least amongst some of the people I talk to with concerns in healthcare and living in Minneapolis and being in public school. It was a big topic of conversation amongst teachers. How does historical trauma affect current generations? And is it just because you are taught, or is it because the way we lead a family, or a fear of dogs, and that's, is that learned behavior from your parents or your elders, or is that actually a chemical change in the neuropsychology? And we're starting to see, and I'm not an expert and I do not even know that much about it, but they are able, or they think, they're seeing difference in brain matter, and this is probably a neurobiological issue. And so that's changing, which is epigenetics. And so that's just fascinating to see that this comes back not only from learned behavior, but there is actually something inherent from this. So call to action, what can we do? Everything. I think we have to start from the beginning and recognizing populations and where everybody comes from and learning this. And it's scary to think about. They don't even teach a lot of history in schools. And are they teaching it from the right lens? And are they teaching it in the accuracy? And we're definitely not learning about this in medical school and nursing schools. So I hope that's changing. And I definitely think these topics need to be taught by people that experience that, have experienced it, come from it, because I think we have a lot to learn. And I don't ever pretend to know what that's like, and if we really, like, the point of being in medicine is to do better and to help. And are we actually doing more damage than good? Has been my big kind of philosophical question. So this is a really busy slide that's probably not all that important, but it's just talking about how expensive it is to do research. Are women, so first off, are women even included in research? They've now made that a law for the FDA and passing of drugs. But what are we looking at? Are we going to get funded for $3, $4, $10 million for studying women that have darker skin tones in their vulva? Probably not. So how do we fix that, and how do we learn more about that? A lot of what we do in women's health, OB care, especially in my little specialty, is we take research from other parts of medicine. There's lots of money for diabetes, and we look at neuropathic pain with diabetes, and then we try to apply that to a vulva or to a female patient that is experiencing neuropathic pain in the pelvic area. So that's really hard. And I have not done research, and I don't know much about it, but I do know we are trying to do research at Park Nicolet, and it's really, really, really difficult. So this is just an interesting table of how many women were included in FDA trials. And so I think people are pretty hip to this kind of stuff with the COVID vaccine coming out, and who was studied, who was not studied, was there long enough? So I think people are understanding this more and more. We have to be transparent, and we have to study. If we're providing healthcare for the masses, we have to study the masses, and we have to study how each individual population reacts, and there's a lot that goes into that, I think. So it's fascinating to me. In reading about trauma-informed care, it was interesting, and these are just a few examples, and I have a very, very strong feelings about most organizations rolling out DEI training and their honesty about the intention of doing this, and are we really trying to make change, or are we checking boxes? But it was interesting reading about, these are just two examples that I pulled up, but they are either starting programs to educate and teach trauma-informed care and where that comes from, and how to help families that are from that. And we're talking about trauma from anything, right? Immigration, slavery, history of abuse, all sorts of traumas, right? But we need to be better informed if we're going to adequately take care of people and try to heal. This is interesting. It's also a busy slide, but on how the programs would go through and talk about what is the pattern and how do we fix this, and how do we fix if we can fix. And fix is maybe not a great word, but start to realize and understand, and what's the route that we can best do this. So there are different algorithms for this, but I thought this one was pretty nice. So back to the two women from the med school talking about more providers of color there. I mean, it's just like robust evidence that this is needed. I learned this probably the most through my experience in Minneapolis and working with doula groups, and I'm learning from a doula group that spoke about having Black doulas for Black moms, because that was that created a safe space for women that were fearful of the medical community and coming to a hospital. And it was just an amazing aha moment of, I hadn't even really thought about that. It was 15 years ago, and I hadn't thought about having that specific care, which is amazing. And now it's really important, and we know that, right? And we're trying to do better. And what Isuroon is doing with their doulas is amazing. And not only for Black women, but specifically for African women. And knowing that someone from your community, someone from your population is there and helping, and can help be the middle person for the medical care until we can get better, or always they should be present, but until we're providing safe care for our patients. So I'd love to hear what people have to say. I'm kind of all over the place with this talk. I was trying to cover a lot, but what are people's thoughts about? I'm really interested in the epigenetic piece and where they think trauma comes from for their populations. I am fascinated with this, with my immigrant population, and generations before us growing up in refugee camps. It's not easy. That's not normal life. How is that affecting the generations that are here and growing up? I just find it fascinating, and there's so much to learn. But then on my side of expertise, I want to know what people see in marketing for feminine products, and I could go on and on and on about that, and more of a feminist rant of why we need these scented products. There was a little bit back there about the historical trauma piece of that, about, it's back to the belief of Black people don't feel pain, and they weren't allowed normal, I'm at a loss for words, normal washing and soaps, and this whole odor thing kind of manifested. And it's I don't have the essay pulled up, but it was called historical olfactory trauma or something like that. And it was interesting that marketing, the US economy seems to be built on that. We need scented baby detergent. If you're going to be a good mom, you have to buy Draft. and you have to use a scented body wash because inherently our bodies are dirty, and we inherently are needing that extra product. So I'm very curious as to what other people think and what people's opinions are, what I'm missing, what I can learn, how I can help better take care of women and better get the word out for helping more women. So thank you.
Thank you, Anna. Yes, please put your questions and thoughts in the Q&A box. Anna, we are truly grateful for your enlightening presentation and valuable knowledge you have just shared with us. Thank you so much. In the Q&A, Sophia asked, are there any specific resources or approaches that you find helpful in addressing trauma and its impacts on women's health in your practice?
Repeat the first part for me. I can't see the chat box.
Yeah, Q&A. Yeah, no. Are there any specific resources or approaches that you find helpful in addressing trauma and its impacts on women's health in your practice, like resources or approaches you can recommend?
No, and I would love more resources. I kind of get bogged down in all the things I want to do to change and better the world. I know when I started as a new provider in 2007, I worked at the Minneapolis Clinic, which is kind of downtown Minneapolis. I've lived in a lot of big cities. I had never been surrounded by people in hijabs. I didn't know about female circumcision. I did from Chicago, but I had never experienced that in labor and delivery. I didn't know about the immigration process and what people go through. And I just kind of had to learn it on my own. And I would talk to physicians about how do you deliver babies with circumcisions. And I knew already from some work I had done in Chicago about how to approach that and have good bedside manner, but man, is that lacking in the whole of medicine. But I had to learn that. And then I was at the Brookdale Clinic, and we used to have the group Victims of Torture. And I was like, what is that? And I take care of a huge population of Liberian women and trying to understand how to even address them. And why weren't they joyous when they were positive pregnancy tests? And then learning just from my colleagues about, well, these women were probably, in the Civil War, they've grown up in the Civil War, all of this terrible stuff. I just didn't know. So no, I don't know of great resources. That's why I'm so hungry to learn. I find people like Fartoon to learn about this. I find places like Everyday Miracles has been great. And I've done a few Victims of Torture telehealth kind of webinar things. So I think it's really, for right now, at least, it's kind of taking it on our own. But if anybody has suggestions, I would love it.
Yeah. It's good to have providers like you who are resourceful and are willing to learn and seek this knowledge. Unfortunately, in our medical industry, the burden of not only representation, but the burden of educating the providers is on the victims. And
it really is.
Yeah, this is
that's victimization again, right? Is that re-traumatizing? And I just have questions and I'm just hungry to understand. There's so much. There's so much.
Who should provide this? It's a huge lack and it's a huge space that needs to be filled and explored, a big gap within the medical industry. And it impacts so many women, like you said, so many generations, and there is no information, no support out there, sadly. So thank you for being so resourceful, Anna, and providing that care.
Well, thank you.
Appreciate it.
Thank you, Anna. I've known Anna for years, and that shows how good soul you are. So don't hang your hat yet. There's so many coming about Isuroon. So We appreciate your support and understanding, just being honest that you don't really have the answers. That
don't.
says a lot. So thank you so much.
Well, and I feel really fortunate to be in such a rich environment. I think Minneapolis has so much to offer. When I moved here, the joke was you can't go a block without hitting a doula, and now it's that doula environment has changed into different cultures, and there's just so much to still learn. And all I really know is about the vulva. So if anybody has questions about that, but wants to, I would love to learn more about all the things I talked about.
Yes, thank you, Anna. Thank you
Thank
for
you.
I appreciate you. To move along and be precise with timing, I want to introduce our next presenter, Judge Lejun Lang. I am pleased to introduce Judge Lejun Thomas Lang, excuse me. Judge Lejun brings a wealth of experience and expertise to our discussion today on infant and maternal mortality rate in Africa. Currently, Judge Lejun serves as the Senior Fellow at Roy Wilkins Center for Human Relations and Social Justice at the Hubert Humphrey School of Public Affairs. She's a dedicated advocate. Her expertise extends to international human rights and the rule of law in developing nations. It is a pleasure to have you join us today, Judge Lejun. Good afternoon.
Good afternoon. Thank you very much. It's a pleasure to be with the Isuroon team and Fartoon. And I look forward to talking with you briefly this afternoon on this important topic. First of all, as a retired judge, I need to talk a little bit about my experience with regard to infant mortality in Africa. In 1994, I started a nonprofit organization called the International Leadership Institute. And we have been working for over 30 years on the African continent and in the United States with government and civil society by invitation. And one of the areas that we have focused on is fire prevention and healthcare, particularly maternal health. So we singled out this area in Kenya, a county called Uasin Gishu that had been the target of ethnic violence and fires and other things that caused loss of life. And we sent over time 3 fire trucks and 2 ambulances and provided a series of training at the request of nurses and doctors in the region. In between the training, we also would go and have benchmark visits either once a year or every 6 months to see if there were additional requests or additional needs that these local communities could benefit from and be able to have us guide as volunteers, guide the change. And so one of those things with municipal local clinics was transportation of mothers who were expectant mothers to the clinic on the day of delivery. So we sent the 2 ambulances so that there would be free transportation to these mothers so they could get to the clinic without having to raise funds or not be able to have access at all because they didn't have access to a vehicle or other transportation. And the way it was described to us is when a expectant mother was ready to deliver and there appeared to be either no one to assist the birth or complications, the mother would be brought in a wheelbarrow to a certain point where someone might have a car and be driven to the clinic, or they might be taken to the nearest road and a lantern held up so that the ambulance we provided could locate the person and take them to the facility. So nothing was easy, nothing was instantaneous. It all required the cooperation and support of the local community. So any work we do is always from the bottom up, having the support of the community, having the vision of the community, and having an understanding of where they want services and how they want them delivered. So with the ambulances have, the first one arrived in 2011 and the second one about 5 years later. So those ambulances have been regarded by the community as moving hospital rooms. They have been very successful in terms of giving the patient a stable way to be transported, as well as the security of having a vehicle that could be enclosed and travel on the roads. We were also able to identify for some of the local clinics that were having challenges with maternal deliveries, a failure of the water supply to the clinic. So sometimes the water wouldn't work. And we were able to get people from the water department to find pipes that had broken apart underground. So it made the water pressure go down to a trickle, and the water was actually running into the earth rather than into the facility. And then we also had been advocating for washing facilities for the doctors and the nurses that used piped water, as well as toilet facilities for medical staff that was not a pit latrine. I think all of us remember during the Ebola crisis, there was a connection between the medical staff using the pit latrines and the spread of Ebola. So that has been a real challenge because replication of traditional buildings has been kind of the mainstay. So advocating for something different takes the elected officials to have that vision. So we organized a number of exposure trips for people involved in the medical profession to be able to come to the United States and come to Minnesota, tour places like Hennepin County Medical Center, Fairview Hospital, and other places, Mayo Clinic, to be able to look at some of the facilities, some of the public facilities, looking at the toilets, looking at the maternity, looking at all these things to decide maybe to incorporate some of those things into their own practice. Now, the one thing that our group should focus on is an organization called the International Monetary Fund. And the International Monetary Fund puts conditions on aid to governments. So Somalia is a recipient of IMF money. Kenya is a recipient. Much of sub-Saharan Africa is a recipient of money from the IMF. And what the IMF does is it starts to gut your health plan. It starts to gut your allocations of health workers. It starts to gut the amount of money that you can spend on medical personnel, nursing personnel, all these things that we hope will solve the Millennium Development Goals, solve maternal health. We are undermined by the International Monetary Fund's fiscal requirements. They're called structural adjustments, which limit a nation's ability to unilaterally meet a need. So when we have something like COVID or tuberculosis or a surge in malaria, a government can't just automatically allocate more money. They have to work within the constraints of the International Monetary Fund for any change with regard to medical policy, medical staffing, any expansion of doctors or nurses. So as a result, in Kenya, in many places in Africa, we are graduating nurses and doctors that are highly educated and being recruited to Great Britain and other European countries to serve their population rather than allowed to be absorbed into their home country. And part of this is due to those constraints placed on government by the International Monetary Fund. So one of those categories that we look at with regard to maternal health and maternal death is unattended births. So when you have lack of resources, lack of trained people, lack of the ability to pay those people who are trained, then you're going to have gaps. Kenya, when I was there before COVID, was implementing a program where if a midwife brought her client to the clinic for the delivery, there would be a financial incentive. And so they were trying to keep the midwife employed, but also have an umbrella of protection of delivery at the clinic to make the outcome more favorable. I think all of us agree that the earliest interventions of frequency of visits to the clinic, being able to have tests, watching for major health concerns like infections, preeclampsia, and other kinds of concerns need to be done early with regular visits and be able to take adequate measures to prevent the conditions from worsening. We have public health systems that are being run with these kinds of restrictions, and we are in a very, very difficult time within the world with the climate adversities, with conflict, with mass migration, dislocation, and the impact of the climate producing nutritional deficiencies and mothers who are in poor health giving birth to babies who are in poor health and lacking the resources and the water to be able to sustain life. However, it seems that much of the literature places the blame on poverty and on the mother rather than on moving higher up with these structural adjustment policies that limit a country's ability to be nimble enough to change the healthcare delivery system to meet these emerging needs or meet things like Ebola or other mass issues like COVID. So we have, with the severe rains, temperature decreases and increases, we have in Somalia one of the highest infant death rates, and those deaths are primarily due to pneumonia, also neonatal pneumonia, prematurity, and birth asphyxia or trauma. And the maternal mortality deaths are due to heart disease and stroke, cardiomyopathy, and also these occur and were measured within 1 week to 1 year after delivery. In Ethiopia, the highest cause of death is obstructed labor. And that's, and then in Kenya, hemorrhages, eclampsia, and sepsis. So we have many, many morbidities that are preventable, but we have a policy block at the top, which is limiting our ability to really move in a vigorous way toward the sustainable development goals. So we're in a position now where we're calling for a midway summit to look at sustainable development goals and calling on countries to do ABC when the countries do not have the ability to make those changes independently. They must be able to get the IMF to agree, which has not been happening over the decades. So we need to be able to have our own eyes on the World Bank and the IMF and have advocates who are following these institutions and be able to say, we need to expand the healthcare and reduce the mortality rates for African women. So I wanted to talk about, in closing, the Dr. Levin talked so much about African women in the United States, and I also wanted to just touch on the Center for Victims of Torture, which is in Minneapolis, which has a number of different programs and facilities, but it is not something that is widely advertised. So people have to have a gateway to be able to get to the Center for Victims of Torture. They are very circumspect in terms of the services. They are very private. So if you go to the Center of Victims of Torture, no one's going to know. And it is something that is beneficial to people who have been through their programs. But in the other countries, such as Somalia, Kenya, and Malawi and other places, the women are basically going to be on a hamster wheel, lacking the ability to alter the course of maternal and infant deaths until at the high policy level, they're able to keep more of their doctors and nurses and allowed to increase their pay, which is also controlled by the IMF, so that they can have adequate services and the ability to reach the population. I want to allow plenty of time for questions, but I think that this whole important area of the IMF having a cap on public health expenditure, wage caps on the ability to pay the doctors and nurses, personnel caps on the ability to how many that you can employ, and also the expansion and modernization and maintenance of a health system is really crippling African countries. So I'd like to be able to have time for questions.
Yes, folks, please put in your questions in the Q&A box. Thank you so much, Judge Lejeune. You just reminded us that on this International Women's Day, it is essential for us as a diaspora to remember the importance of supporting African women who are dealing with high mortality rates. You know, we must, like you reminded us, we must stand in solidarity with our sisters and advocate for a better healthcare access. These are alarming statistics, and even more alarming to know that we have competent and trained healthcare providers within these nations, like you just spoke about Kenya, but yet they're being outsourced and providing this care for Western countries.
Yeah.
Yeah. Thank you.
Yeah, I concur, Najma, Judge. Thank you so much. You've always been like amazing informer. This I was having a meeting last week with a company that's here in Minnesota, and they were talking about bringing African nurses here in Minnesota to employ their company who don't have staff. And all of a sudden I was like, wait, why are you bringing our African talent here? And remember, they're not going to be paid as a nurses here. So it's going to not only impact what IMF is doing, it's starving our talents. So then that opens up the door to our talents coming to the Western world. That's a form another of a discrimination and racism.
Exactly.
And so I'm just here in the IMF. I always wonder why these things happen. We have doctors who are getting paid $200. There are clinics that people are open and then they're not able to maintain or sustain their staff. And so the question is, why does Africa even need an IMF? Why can't we clear our own funding? Why are we beholden to these guys?
Basically, countries get funneled into the IMF as kind of the place of last resort to fund the government and government services. But the IMF comes with all these strings attached that if you get money to make your government payroll and avoid a disaster of the civil service, these are the other hidden claws that are put into your system that don't go away. And so being able to limit how much you can spend on schools and education, wiping out often preschool programs, and also specifically limiting healthcare and limiting a nation's ability to provide universal care for health is part of the IMF baggage.
Okay, thank you. I think Najmi have questions. Thank you, Judge.
Right.
So let me see. Yeah, Linnea asked Judge Lejeune, are there ways for us as concerned people to put pressure on the IMF?
Yes, the IMF, there's women's groups that have had, white women have been following the IMF for decades through their own groups. And I happened to stumble on one when I was traveling back and forth on the continent, and they called it Eyes on the World Bank. And that's what gave me the flag of how much control and limitations were going on. Their focus was on women's issues, but it was not intersecting with African descendant women across the continent or in the United States. So we need our own organization that has our own priorities and is able to go to the World Bank and put pressure on them with regard to healthcare. I attended the last meeting, I attended the World Bank, which was an outreach to the African diaspora. I went to a meeting in Washington about 10 years ago, and basically the World Bank wanted to take all the overseas remittances that the African community was sending to Africa and take over and control those remittances. So there weren't too many people in the room who were interested in the World Bank siphoning away the independent remittances that were being sent. But they were just, the World Bank was so obsessed with how much money is transferred from the United States to the African continent that they don't have control over, that this is a repeated issue. So we have leverage. They know how much money we're sending to these countries to keep these countries afloat. And we want to be able to have some control over spending and how it's prioritized. But it's again, if you're not at the table, you're on the menu. And so these kinds of things are done without our community being notified.
Thank you, Judge Lejeune. Next question is from Elizabeth. Elizabeth says, my experience within American culture is the US is not educated on how to support new mothers. Elizabeth is asking, how do we learn or educate providers from Somali culture, and how do we support women who have given birth? I don't know if you could shine light on that.
Well, I think she's 100% correct. We have a medical apartheid system in the United States. And whether you're a descendant of slavery and your ancestors are from Africa, or whether you're an immigrant who has come, you are going to face the same medical apartheid when you are in the hospitals. And one of the studies that recently came out echoes the experience of many of us who are older, and that is you have a better outcome if you have a Black physician and Black nurses and others attending to you, no matter what insurance company you're with or what hospital you're in. These things are significant. So when I was, my parents were living in Minnesota, and the situation was so dire. Our Black doctor had limited privileges at Fairview Hospital, and the Black families who were admitted to Fairview for birth were put next to the mortuary. And so the doctors were dealing with dead people and then running over and dealing with childbirth and deliveries. So my mother was informed, and she immediately made arrangements for her to go to Kansas City, where I was born, in an all-Black hospital. And so it's come around full circle that science of who attends the birth and who cares for you has a monumental influence in your outcomes.
Right. It does make a tremendous difference. Last question. Thank you again for answering that, Judge Lejun. Last questions coming from me is that how can the diaspora community effectively support your efforts and the efforts to improve healthcare access and reduce these alarming mortality rates among the African women? I know you spoke about Somalia and Kenya, but yeah.
Well, I think being able to form our own organization, as Fartun has suggested, and being able to be aware of when these meetings occur, and then being able to share that information once you attend a meeting. Sometimes we get so excited about being picked and attending that we hide the results. So we need to be able to have an agreement up front to share that information and have a set of goals that we want to work toward. And then now with social media, with Zoom, we don't have to travel from city to city or continent to continent. We can share that information so that people have real-time understanding of what the obstacles are. We have that collective ability to get the attention of these countries, get the attention of their funders to threaten reduce funds if these goals are not changed. But it's a matter of being at the right place at the right time and then knowing where the pressure points are. So I look forward to a follow-up meeting with Fartun about how we're going to get started.
You got it, Judge. I'm already on the IMF thing. I think you have such a great experience, and we have so many young and old and middle that were dying to get Africa, the colonizers' hands off. And the fact that right now, one of these organizations, they already have people on the ground recruiting nurses from the continent. And that gave me a nightmare. And so this IMF thing, we're going to come together. And then I think our action, Najma and everyone else, the takeaway today is going to be a lot. But the first thing is, how are we going to fight this IMF? And I'm not shocked that they want to handle the Hawala money, because that's money that they can't get it. Imagine if they had the money on their hand, we would have been starving to death. Africa wouldn't be
Exactly.
really faster.
Exactly.
Thank you so much. I like the outfit. The ancestors are speaking to you.
Thank you.
Yeah.
Thank you.
Thank you. Thank you again, Judge Lejun. Your insights have shed light and inspired us to reflect on the challenges we face globally. Thank you for enlightening us.
My pleasure.
Yes. Yay, y'all. We are on time. I'm so glad. Now it is my pleasure to introduce our next presenter, Dr. Altricia Foster. Welcome, Dr. Foster. Dr. Foster is a leading expert in public health, vaccine science, and infectious diseases, CEO of Foster Bento Scientific Consultants. Dr. Foster not only is a respected scientist, but also a talented baker. Yum. She's behind Sugar and Spoon Desserts. Her book, Cake Therapy, and podcast delve into the healing power of baking. Please join us as she shares her insights on finding healing, navigating trauma after loss. Welcome, Dr. Foster.
Thank you, Najma. I'm going to share my screen. Hi, everyone. Let me pull this up. Share. Let's start. Hi, everyone. Good afternoon. Happy International Women's Day. Hey, Fortune. I'm excited to see you. And I want to say thank you for inviting me yet again into your space to speak with the individuals who've joined this webinar. And I'm grateful for Isuroon, but I want to say thank you to Najma. Can I have a Najma, guys? Oh my God, I want to applaud Najma for showing up as, as royal as she has been today and before this webinar. She's been super awesome. So I'm really excited.
You can have her. She's
No,
ours.
I'm really proud of her. I'm really, really proud of her.
Oh, thank you, Dr. Foster.
Yeah. So Najma mentioned in my intro that I wrote a book. So last year I wrote a book. I published it on International Women's Day. So I think it was the 10th last year. But in this book, I shared about my love affair with my mother. And this morning I had the opportunity to share on my podcast, the changes that has happened since I wrote this book last year and the profound grief that has taken over my body, that has led me to some form of brokenness at this point. So I'm happy to be here to talk about um, trauma, healing from trauma, and how I'm navigating this stuff. So before I start, I know that, everyone deals with trauma differently. And I'd like to, express my empathy to individuals who are grieving or dealing with any trauma or loss at this time, because there is a deep sense of profound brokenness that accompanies our shared stories and this journey. So let's take a quick look at how, understanding trauma and loss. The definition tells us that in the context of loss, right, it refers to a profound emotional and psychological impact experience, which is often distressing. It can be life-altering. And this type of loss, whether it's the death of a loved one or the end of a significant relationship or any major life change, can elicit a range of intense emotional responses. And like I mentioned, I'm really experiencing that now. But this type of emotional turbulence sometimes disrupt our own sense of security, stability, and you often lead to some profound, feeling of grief, I would say. So as I'm going through my own trauma, and I'm currently taking a deeper dive into it because I'm trying to understand it for myself. So currently writing a book about the loss, forgiveness, and the power of letting go, and the healing power that comes with trauma. So there are three forms of trauma here. There's acute trauma, chronic trauma, and secondary trauma. And in the acute trauma, it occurs as a result of a single distressing event, such as like a sudden loss, traumatic incident. Could be a quick loss of a parent, loss of a puppy or something. In chronic loss, it arises from a prolonged exposure of stressors, which includes like probably like ongoing financial issues or struggles of persistent life challenges. And the secondary outlook here is the emotional toll that experienced indirectly through suffering of others, common in professions like caregivers and emergency responses. And this kind of showed up in the amount of suicides that were experienced during the COVID-19 pandemic within our caregiving community, with our medical professionals, succumbing to this type of trauma. So for me, I am experiencing profound grief, and it's a loss that actually triggers a spectrum of emotions. I run from disbelief and anger to deep sadness and even acceptance. And these types of losses, such as death of a loved one, a relationship breakup, a job loss, loss of a pet, loss of a friend, miscarriages and infertility, these type of losses may present unique challenges in their own, but what one has to do is understand the knowledge of these challenges associated with each type of loss. You have to understand this because it's crucial in providing effective support for you and finding, unique coping strategies for yourself. So here I have a pretty diagram that shows you what the grieving process looks like, or it should look like, right? But it's not the same for everyone. The stages of grief, as is shown here, often referred to as a Kubler-Ross model. And this includes denial, anger, bargaining, depression, and acceptance. However, it's important to know that grief is a fluid and highly individualized process. And many individuals may not necessarily go through these stages in this linear fashion, and the intensity and the duration of each stage can vary greatly. So let's look at denial here for a little bit. So once we start experiencing grief and we get into our denial stage, denial might not be the initial response for everyone, because everyone shows up and experience their grief differently. And if we're talking about, like, as I was processing what my mom is currently going through, I would say I've denied it for years leading up. And I'll pause to share my story. My mom is a 20-year breast cancer survivor. She suffered from Parkinson's, and she's at the end stage of this, where she is suffering from dementia. And for me, witnessing those signs and the subtle changes that I've seen in mom over the last 12 months, I denied it because I didn't want to actually believe that my mom was getting there. But my brother and I kind of dealt with this process differently. We're grieving our mother's decline separately. But for me, I was in denial for months, and I went from denial directly to depression. So this is not a linear process at all, because right now I've moved back from depression and I've gone to anger. So if we're using a monopoly reference here, so it's kind of like I got out of jail, I went past go, and then they sent me back to jail. So I I skipped all those steps because I went to depression, and then now I would say I'm slowly moving my way towards anger. And this is very fluid. There's no prescribed timeline, and everyone's feelings of grief and emotions are unique. Sometimes these emotions become so intertwined. You don't even know when you're bargaining, you don't know when you're angry, and then you don't even know sometimes when you're even at acceptance, because grief is so sporadic and it comes in waves. Healing approaches. So as I'm taking this deep dive into writing my story and sharing this profound journey of pain and heartbreak, I've looked up what I wanted to know. What were some of the healing approaches that I could take to be able to respond to what I'm going through? So these are all evidence-based approaches. Some I've tried and others I've come across during my research for this book. Is that there's cognitive behavior therapy, which is referred to as CBT, and it's widely recognized. It's a widely recognized evidence-based method which focuses on you identifying and changing the negative thought patterns and behavior. The cognitive reconstruction, or the cognitive restructuring, is identifying and challenging your irrational or negative thoughts as it relates to what's currently going on. The mindfulness approaches here involves cultivating present moment awareness without judgment. It has roots in ancient contemplative practices and is often used in various therapeutic interventions. The dialectic behavior therapy that I mentioned it involves mindfulness skills, emotional regulation, and some interpersonal effectiveness. The interpersonal effectiveness here is enhancing communication and your relationship skills, but your mindfulness skills are developed here by developing non-judgment awareness of thoughts and emotions. And one has to often bring it to the acceptance and commitment therapy, which is referred to as the ACT. It also includes mindfulness, values of clarification, and commitment action. There are other forms of healing approaches, and my favorite one of them is art and expressive therapies. And that brings me to talking about cake therapy, art therapy, music therapy. I am an avid believer of the power of using artistic modalities to, to respond to trauma and to help you heal. As I was going through postpartum depression, that as was talked about today, I've used cake, I've used baking to really explore some feelings and some intense heartbreaks that I've experienced throughout my life growing up, to be able to heal. So I highly recommend cake therapy, which I'm teaching girls in this foundation now to use baking as an outlet to responding to their own personal traumas. I highly recommend that even though we've talked about healing powers of art, I highly recommend that sometimes the art form doesn't have all the answers. So one must always seek professional help. There's individual therapy, excuse me, that looks at engaging in a one-on-one format, and that requires like a mental health professional to interact with you, such as a psychologist or a counselor. Group therapy is awesome if you're okay with sharing your business in a group session. But what this does though, it brings a sense of togetherness, like you're in a space where individuals can share their their similar situations. So there is a profound similarity in conversation, and group therapy works. The the benefits from group therapy that I've seen, it actually fosters a sense of community, and it allows people to really share their experiences and provide support of each other. The psychiatric evaluation and medication management is seeking evaluation if necessary. And this definitely addresses some of the conjunction and this the benefits of medication and seeking psychiatric evaluation addresses your mental health condition totally. Online therapeutic platforms, I've used them significantly during the pandemic. It's a space where you just, you're using your virtual tools and your virtual technology to be able to respond to what you're going through, and you just do this at home. This provides some flexibility for you, and it's even convenient, if you're thinking about it. But some of the self-care practices, outside of seeking professional help, those include mindfulness, meditation, physical exercise, journal, trust yourself in writing your own story, write it down. There are artistic expressions like, we've mentioned before, reading and learning. There's bibliotherapy. There's social connections. There's Bakeful. There's cake therapy. And there's mind and body practices that are often out there that individuals can attest to. And there's aromatherapy and sleep hygiene. I've used a couple of these as I'm working through this grief and this brokenness that I'm dealing with. And I say that I'm profoundly in a great place because I've adapted to some self-care practices, and it's highly promoted these days. What's key here is to always try to maintain and build your support system. It's very significant. A strong support system helps you with your own personal emotional validation, and it plays a pivotal role in how you navigate grief and loss. An emotional validation support system, it provides a safe space, and we all want to be in a safe space when we're going through we're going through emotional duress, and it helps you to normalize your own grieving in this process. There's also a practical assistance. And what practical assistance is friends and family who can offer practical help on your daily task. So if you know someone who is going with something, like show up for them, help them to ease the burden of what they're going through, just showing up. I think the benefits from this is that it allows individuals to focus on their own emotional well-being without feeling overwhelmed by the daily responsibilities. Imagine you feeling down and out and you're in bed and your group of friends show up and said, yes, I'm going to help you today. I'm going to help you get out of bed, but I'm also going to help you go through this. Reducing your sense of isolation. When we are going through stuff, we tend to want to be alone. And grief is isolating because you're going through this experience alone. But a good support system, like I mentioned before, it helps you to really combat loneliness and it provides companionship. And you just simply need to get out of the house. It really does help. And the benefit of reducing isolation, it really does impact your mental health and it smooths the grief journey. Yeah, as mundane as it might sound, it's like grief can be a smooth process. So I would say get out, reduce your time, your isolation time. It's the time that you're spending with yourself. Just loosen up and hang out with your friends and just developing your own personal coping strategies. That's important too. You can journal, you can send yourself messages, leave messages on your mirror. So you have to also invest in finding ways to be able to cope and going through, you know, going through grief and finding your own support system. And let's talk about the support system, the benefits of that, and it's a big deal as you're going through grief. And so, as a supportive friend, you have to actively listen to these individuals. Actively listening fosters trust, and it helps grieving person feel heard and understood. And I think what this does is it gives it heightens the validating emotions, and in this space it avoids judgment. So just actively listen to your friends. Once you hear them start complaining about, or mentioning that they're going through something, I think it's highly beneficial to them. I say empathy over sympathy. Empathy creates a supportive atmosphere which allows a grieving person to process their emotions at their own pace. So be there, but don't be too sympathetic. Guide them, hold their hand, allow them to get there, and avoid cliches. Using authentic and thoughtful language around in response, like sayings like it's for the best, you know. Just avoid those cliched statements. Respect for the complexity of this person's grieving process will definitely help them as they're, going through their grief and trauma, and respecting this person's timelines. Be patient and respectful of their timeline, because grief does not follow any schedule. You can't say, oh, it's time for you to get over this. No, it's not time, because I haven't gotten through these stages of grief that I'm supposed to be experiencing. I have not accepted this yet. So just be patient. Respectful communication often ensures that the grieving individual doesn't feel pressured to move on too quickly from what they're experiencing. And in wrapping this up, I want to take some time to reinforce a message of hope and resilience. We want to highlight the inspirational stories, focus on the individual's personal growth, and empowering through coping strategies. When we share real life stories of individuals who've navigated grief and loss, emphasizing their resilience and eventual rediscovery of hope is quite impactful. The inspirational stories that they share or what they hear will provide tangible examples of how people can emerge from challenging experiences with a newfound strength. And when we help someone to focus on their own personal growth, This will emphasize potential for growth that often accompanies grief, someone's grief journey. And these challenges can lead to self-discovery and resilience. And that would often, lead to shifting the narrative from solely overcoming pain to embracing this person's own personal growth that instills this sense of hope and empowering through coping strategies. I would say adopt practical coping strategies, not just just the practical coping strategies that empowers you to be able to navigate grief. And it's often effective in building one's resilience. It equips individuals with tools to actively cope and fosters a sense of self-control. And the other messages of resilience that I would mention here is encourage peer support. Support your friends, show up for them, share in their journey, and offer encouragement. But remember to forget using the cliche. It's it's not for the best. It's never for the best. Showcasing resilience in adversity. What we want to do here is to share examples from various contexts, such as historical events or societal challenges, where resilience has triumphed over adversity. Affirming a strength in vulnerability. Often we need to be able to acknowledge the strength found in vulnerability and courage. And we want to create a supportive community, offering professional guidance. And sometimes you simply just need to bake. And I pause for questions.
Yes, please. Thank you so much, Dr. Foster. Please put in your questions in the Q&A box that is available. My heartfelt gratitudes, Dr. Foster. Thank you for dedicating space to help us and others find healing and for providing practical and effective ways to cope with grief. I really appreciated that. You come from such a compassionate perspective, especially in support to those navigating through such a difficult time. It's easier said than done. A lot of like practical supports you offered, it's honestly easier said than done, but like you said, you just got to go through it. There's not a deadline, there's not a time frame. Let's see if there are any questions. Someone asked, do you offer cake therapy to the public, and do you lead workshops?
Yes, we do offer cake therapy to the public. You can find all that information at thecaketherapyfoundation.org. I do workshop, but mostly cake therapy. Cake therapy is for women and girls who've been impacted by the justice system, the foster care system, and have been in and out of a home placement. But we order a corporate curriculum, we order like a conference style curriculum, but we do also have like a 36-week curriculum.
Sounds wonderful. Yes, please go to her website, and we'll be sending out resources to all of our attendees that they can connect with you that way. Thank you, Dr. Foster. Any other questions? Elizabeth asked, what are some of the ways that the therapists can work with families to develop ways to demonstrate support for women who are struggling with postpartum mental health?
I'm not a licensed therapist, but here's what I've done as I've experienced postpartum mental health. I've spoken to individuals in the profession who are like me. I look for individuals from the African American community who often understands my own personal traumas, and I have baked through it. So I would say be open to having those conversations, be true to yourself, and step into the space, willing to have conversations. Whatever you're going through, and you owe it to yourself to be as authentic and open in conversations.
I was going to say there's so many gratitude and thank to do this. As you were talking, I was acknowledging my own grief, and I was like coping mechanism and what did I do? And there's so much and so many of it. But what I question, my questions right now, because there are a lot of traumas and grieving that's an immigrant woman right now are using a lot of ways to numb themselves to the alcohol, the drugs, the sex, the all the risk on the world that they're taking because they don't know how to identify this pain and someone else is in charge of. I was talking to a trafficked single mother and I said, when does this happen? And apparently it started when the husband dumped her because he got married to another woman. But then her guilt was coming from that she was in America for 20 years and never went to school, never went to learn. So there's a lot of regrets of like, I would have been independent, I would have been this, I would have been that. And I swear to God, I remember my mother, may she rest in peace, telling me when she got upset to say, look at me, I cannot read and write. So what that did to me was brought back like 50 years ago conversation that my mom will tell us how she felt inferior and insecure because of the lack of education and the choices she made being a home state mom. Or those days she didn't have, women didn't have opportunities to be independent. So what can we tell immigrant women or even any women that will make a decision to it's a family decision, you make a decision to with your partner, what can we tell these women and say, these are things that happen to women, but don't make worse choices by numbing yourself with alcohol and drugs and also becoming sex addict.
Yeah. So my advice to that woman, and I'm speaking to that woman too, because to lean into why you made the decision to begin with, and lean into that some of these decisions are innate to us because of our own personal socialization. These are things we were taught as young women growing up in our own countries, right? And then we come here and it's a battle for the immigrant woman who comes here undereducated or even uneducated to be able to assimilate what through dialect, through language. There's a unique barrier. And I think what the woman needs to do is to really immerse herself in what have you, in terms of you being a stay-at-home mom and not having achieved what you thought you could be, but look at what you've molded your children to become because you've made this decision for your family. And it's not easy, Fortune, because my mom was here and my mom felt that way. Her assimilation was harder. It was easier for me to assimilate into this space as an immigrant woman because I came here for college. But then the trauma that follows you, it's no different. You could be educated as much as you want, but there's these generational trauma that tracks you as you walk like a flood on the ground. So I would say to that lady, it's like, pull back, see what you've created. Some of this is not just necessarily monetary. It's the children you've raised. It's the home you live in, the food or the meals you provide for your children. I would say to them, let's beg through it. One, that would be my answer. And then the second one would be, applaud yourself. Just go easy on yourself.
Thank you so much. You have the last word.
Yes, thank you so much, Dr. Foster. We really appreciate your time and just creating the space and sharing your wealth of knowledge with us. Checking in on time, we really are moving through our conference, which is good. We're moving swiftly. That means it's enjoyable. Yes, we have about 48 minutes left. Now, allow me to reintroduce our next speaker, Fortune Wali. Our second to last speaker. Fortune is the CEO of Isuroon. Fun fact that should not be messed with is that Fortune is a trailblazer in women's health and advocacy. She has over 2 decades of experience in the medical field and has garnered international recognition for her efforts in addressing reproductive health, mental health, poverty, and policies insights. Welcome, Fortune.
Thank you. Someone has my PowerPoint. Yeah. So, well, thank you for those who stayed. I think this videos that we're recording is going to be beneficial to next time when we post it. Today, I'm going to share, I don't know where my PowerPoints, but I can speak while they bring in. We are talking about, so Umi talked about, Judge Lejeune talked about reproductive health challenges, and he talked about so eloquently about, am I in charge of this or someone is in charge? Okay, thank you. Let me pull this thing up. I don't know where I am. So what I wanted to share was years back, because we worked on FGC years back, and we couldn't understand why the mainstream providers were humiliating, women with female genital cutting. And so I've seen in the labor delivery, I've seen after the delivery. So we reached out to Bush Foundation and we said, can we get funding to talk to healthcare providers to understand how much they know about female genital cutting, their knowledge, if they even know what is going on. So this is what we did. They fund us. And so we were able to really collect amazing data that showed what Anne talked about. They actually, most of them have no clue how to serve women with female genital cutting, plus the bias that happens in labor and delivery, the early intervention, preventative care that these women with female genital cutting suffer. So I just want to share with you quickly and then give you tips about how to care women postpartum and after she has the baby and goes home, what you need to do. Let me see. Am I in charge of the clicking? Can you click next? Well, these are the beautiful pictures of Somali. Generically, I always go back to identity. The picture from left is woman from 1900s? And then this is Iman, who is a Somali model. You can see the difference. It's just because of the difference timing, but they both look gorgeous. So this is the woman from the left is always, I need to go back to ancestor and where we came from. Next, please. So again, this is just engage, just participate. If you really want to connect us later, send us an email, or you want us to sit down and go into this research result, then we will do. Next, please. So the Bush overview, we worked big time because this is a passion of ours. The East African community we've asked was Oromo women, how I define East Africa, Oromo, Sudanese, other Ethiopians, Kenyan women, primarily women from East Africa. That's who we engaged. And then because we asked a lot of questions, I just picked up question 1 and 7. Next, please. So the question 1 and 2 just answer their gender identity. 92% obviously were women and 8% only men. The total number I think was about 295. Some of the questions I see some still data showing us some people are finding the questions and they're doing it. Medical doctors are a nurse practitioner and a physician assistant. Next, please. And then ethnicity, we ask 9% white, 4 Black American, and then 2% Hispanic and Asian mixed. And then we also asked their year of experience because what we were trying to collect was how long have they been in the healthcare system. And then 40%, like you can see, it's more than 20 years. And then only 2% said they were in less than a year. So that tells you the majority of these doctors, providers who respond, they have significant time being in the healthcare, even if still they're not fully medical doctor. Next, please. And then here where it comes the problem. women with female genital cutting have reported humiliation. Remember, female genital cutting women in the continent, in the Western world, they dehumanize. They make them, everyone is up. They say it's abhorrent. It's violation of women's rights. The Western has every opinion on rights about women who have gone female genital cutting, and then they show the side of a Black women that are very barbaric and very this and very that. And so when women go to see their providers, the first time that mom gets pregnant, then she sees the doctor, that's when they start the highest maternal depression that we've seen. It starts from, ambulance. It starts from really the reaction of these providers, very arrogant, very not even humane. And then instead of understanding, oh, this is an immigrant, they came from another world, it's my responsibility to care for right now. Their judgment and their disgust, it shows their face. And I've seen a ton of them in labor and delivery. And I've even seen myself, as someone who worked in healthcare for so long, I've seen how they treat women. So here goes 8%, they understood very high, up 30% above average, 17% practically. You can see the huge disparity here on who understands female genital cutting. And right now, like the continent is, Somalis and East Africans, they're a very young community. They're having babies. They're going to be the largest young families that are right now having babies. And so you're probably going to see many East Africans are going through the labor and delivery, are going through the process of getting early prenatal care. And we talked about the disparity of prenatal care. And we talked about the disparity of early intervention of cervical cancer, what Anne talked about, those infections that are preventable, that you see a doctor, they're not going, because I've heard stories where a provider would not even learn if they have a 1 or 3% of East African. They're not assuming, how am I going to get educated? So I know how to do a pelvic exam. I know what kind of speculum to use. Some of them, they just take the first speculum they have. They're not putting water to make it warm, not putting a gel. They just jam them in there. And it's so inhumane, and it hurts. It hurts badly. The women bleed. And so who wants to get experience in that? As soon as the childbearing time ends, you wouldn't have any time that you give our Somali elders for her to go and check cervical cancer screening. She'll say, oh, my dead body, mama, I'm not going to see that doctor. Last time I went, I was bleeding a whole day because they did something bad over there. So let's go to the next slide, please. And then again, it goes down here. It's really working with women who have a female genital cutting. They call it mutilation. Let's just go out right now. People are having a complete sex change. Man is they're removing his whole genital and making a vagina, right? And they're making a woman's vagina into a penis. But that is being called what? Sex change. But ours, what are they calling? Mutilation, dehumanization, all that bullshit that they do, right? So right now, I don't want to see anybody talking about female genital cutting in a disgusting way, because again, this shows you the different purposes of language. Someone who's going through that, that's their right. I'm not against them. But someone, the way that these surgeries and these things are happening is a choice. And also, it is also discriminatory for where Muslims are being told, again, it's another way of dehumanizing and making us barbaric, is the Muslims are doing this. This came from, if you Google female genital cutting in the MAB world, 75% of where female genital cuttings are performed are Christian-based countries, and only 25% are Muslim world. Yet the whole Western world in dehumanizing, in making this barbaric thingy, is done by the Blacks, but also is done by Islam that's controlling women. So right now, with all these sex changes, with all these choices, I'll be challenging everyone I hear talking about female genital cutting as a barbaric thing, because we could have a different conversation. So most of the providers, they don't really know on that. Some of them actually told me they really got traumatized when they see women with female genital cutting. I don't even know what happens into the labor and delivery. Next, please. So then, like, how do we do postpartum care then? So the biggest problem we have right now, I'm a doula right now, and I've witnessed first woman I went through the labor. She had so many hours in labor, a horrific pain. She didn't need to do epidural to reduce the pain because she was already busting, so much pain. But after the baby came out, they cut so the baby's head can come out. The doctor just said, yep, the baby's out, and she walked away. And I said, where are you going? The baby just came out. You just cut this one left to right, up and down, and you're leaving to who? What is she supposed to do? Oh, no. I'm not suturing her back. This is done anyway. It's unethical. It was illegal. I'm not gonna suture her back. I was like, really? Is this your vagina? Can you just tell me? Just say it. You need to do it as you find it. Put it together. You just like created a freeway. You need to put it back. Oh, I'm not going to put it back. That's unethical. It was a scene. But this woman, what is she telling me? Fartoon, leave it alone. I don't care. Because she's been in labor for 24 hours, right? I've witnessed this mother had so many ways that this doctor cut it. And she went, what was she doing? She was projecting her white feminism and her attitude towards a woman who just went through so much pain. And then she cut her female genital cutting however she wanted to have the baby to come out. Yet she had the audacity to say, I'm not going to put it back the way I found it. So after screaming, like literally screaming top of my lungs to her, another doctor came in and he said, listen, you need to really clean this up. That's the word he used, clean it up, right? And what she came and she spent an hour putting back the cutting that she did, right? And so finally she listened to other people and I was just beside myself. And I realized how many women that go through labor, that have female genital cutting, that have been cut in the corners, that people are not putting it together, that has right now, that it healed, and all these adhesions, different layers of all female genital cutting tissues that are laying around. No wonder why women postpartum depression is very high in the community. So what I have been doing was any woman I see who is in depression mode, who just had a baby, I will say, were you cut? Yes. Were you put it back? No. So we could be having so many victims of abusive labor and delivery system. So what we are going to do is educate our families, but as well as maybe have a legal team put together, because we cannot have a labor and delivery doctor or a nurse or a midwife projecting their attitudes about what they believe in female genital cutting and cutting these moms in different ways and then saying, I'm not going to put it back together. Next slide, please. So what is the tip really? We talked about here, lack of training. Yep, lack of training. Find a credible source to get trained. For God's sake, understand culture. Understand immigrants doulas are now doula programs have been Black woman thinking. Now it's becoming a middle class white woman. We got pushed out and because of some policies. Next, please. It's again, what I've witnessed at that hospital and that labor and delivery, absolutely vigilante, white women becoming like, I'm the savior, this is unethical, I'm not gonna do this. It's not your vagina. You need to find how you cut it. If you cut it, put it back. That's all we're asking. Nobody give a shit about your opinion. It's someone else's vagina. If she leaves the hospital and she has all these layer of adhesions, extra tissues hanging around, imagine the damage you're doing to that woman. She would never have another loving relation with her husband. She will be insecure, and you're reminding her all the trauma she had gone through, right? Dehumanizing BIPOC women with female genital and not female genital, address that. The world is changing. Next, please. what are we doing? You know, we've trained 9 doulas, 8 Somali doulas and 1 African-American woman. We're opening our birth center. We're not waiting anybody. It would be, that's what we're getting busy on. We are in the process of getting birth center, open a clinic, and then we're offering trainings and advocacy. Next slide, please. Questions? I get worked up.
Thank you. You're so passionate. Love that. Please put your questions in the chat box for soon.
What about the corporate programs?
Ooh, do you want to talk about how women get, especially when seeking out doula services at Isuroon, how they get partnered with a certain doula and like just the intake process? Can you talk more about that?
Right. So right now, I think Mother Baby Center is referring our fabulous Ebony and Leila and Asha are working. So it's a referral system. They can do it from our website or they can call the number. And it's really simple to get it going. And that is a new thing right now that we're doing. We already have referrals. And so it's either contacting Ebony or doing the online referral form.
Okay. Ebony mentioned and wanted to add that there are a lot of benefits in having a doula present with you. One that's not only culturally specific, but competent and is advocating for your rights. We will be sending out resources to our attendees afterwards, but Fortune, you were a great example of the importance of having someone in the room advocating for you. Being in labor for over 24 hours, you're not thinking straight. You're not in the right headspace, you're in pain. And just to have that mentality of that doctor is insane. So thank you for being in that room. There's more people needed like that.
But that's why our doulas are going to be different doulas. And it's not only going to be, let me help you. And, you know, doula benefit, we as the Black and brown women natives use doulas. We didn't were relying on the Western medicine. We were relying on our own doctors and our own, not doctors, mamas, grandmas, right? We know when doula is around less pain, right? Low, the birth is great. You have someone who's helping you. When I was getting trained, the tear that happens to women because you're using a warm water, keeping that place warm so it doesn't get, the prevention about the tear. After the labor, knowing someone is there, she goes straight into sleep, showering, giving her food. It's like it helps the partner. It's almost you have your guardian agent, angel around you. But what needs to be happening is our doulas are not going to be just, let me have you, baby. They'll be watching what these doctors do. They'll be advocating for this one. But also we're going to be also training allies. Not every clinic or every hospital would get the woman that we serve. We're going to be actively advocating and say, so-and-so hospital did awful thing to this woman. Do not go. So these corporations will fill their bucket. Because we're no longer having any victims, and I only need three births to go, and I myself will be the trainer doulas, and we'll be training more doulas of color and allies of white women if they want to.
Right. That is so needed. Thank you, Fortune. Just echoing Anna in the chat said, so energized by your passion. Cannot wait for more Somali doulas, way past time for their presence to be more common. We need you and all doulas.
Much love. Thank you so much. Thank you.
Just to facilitate and keep track of time, do we have Mary Turner on as well? Just double checking.
No, we don't.
No, we don't. Okay, that's fine.
So we can show, so I don't think she's sitting on the region's orientation today. So I can't wait to
Oh.
hear Antonia Wilkinson.
Yes, no worries. No worries. We just wanted to create an opportunity for one of our esteemed board chairs here at Isuroon, Mary Turner, to speak. It's always wonderful to have her. But it's okay.
She's amazing. Someone said, can you speak more about your corporate programs?
That was for Dr. Foster earlier.
Okay, great.
Yes.
Okay, see
Yeah,
ya.
Dr. Foster. Yeah, just to crunch on time, we have Dr. Antonia Wilkinson. She unfortunately could not be with us in person today. However, she took the time to send in a video to contribute to our learnings. We're always thankful to have her. She's incredible. Dr. Antonia is the principal consultant of Equity Strategies LLC, where she leads efforts to improve the lives of disenfranchised and vulnerable individuals impacted by inequities. Please, let's take a moment to watch and learn from her video.
Hello, everyone. I'm Antonia Apolinario Wilcoxon with Equity Strategies LLC, an organization that I created in 2019 to work and align myself with community, elevating the concerns that communities have about health inequities, about the absence of voices at the table where decisions are being made about communities, and about communities who are sometimes left behind. And I should say many times left behind, because we have a high degree of inequities across many sectors. But today I would like to address this effort on the communities that are centered here today. I would like to congratulate Isuroon for the celebration of International Women's History Month. And I am very grateful to be here to address you for a few minutes. I'm going to share my screen so that you can see my slides, and then I'll come back at the end. Thank you. I'd like to congratulate Isuroon, a grassroots organization working for the health and connectedness of Somali women and their families so they can thrive in Minnesota and globally. With Isuroon, women build their own health and wellness, economic self-sufficiency, community engagement, and leadership. And I took that from Isuroon's website. But I also would like to make sure that I provide my congratulations
What happened to the video? Please let me know, Isaac.
There was just an issue. We're gonna try to reload it and start it again.
Okay, thank you,
One
thank you.
second. Yeah, no problem.
from Isuroon's website. But I also would like to make sure that I provide my congratulations as well as a debt of gratitude to Fortune Welly. She's the founder and CEO of Isuroon, and I appreciate her presence in our communities because she is a generous gift from Somalia to all of us here in Minnesota. She has a medical field training, which she obtained while living overseas, and she brought those skills and much more to work in this community. I admire Fartun for fiercely developing Isuroon into an organization based on strength. I admire her and I'm grateful for how she nurtures a relational approach to help Somali women and their families build self-sufficiency, agency, and maintain healthy lives. And I admire Fortune as a woman of faith, centering her life in elevating a voice and action to support and advocate for immigrant and refugee communities to have equal access to resources and services. I would be remiss if I didn't elevate the voice of one of our North Stars, Harriet Tubman. And I was happy to find a picture and also a quote by her, which I would like to center our conversation and our hopes today. And she teaches us that every great dream begins with a dreamer, that we should always remember that we have within us the strength, the patience, and the passion to reach for the stars to change the world. We have in Fartun such a model. I'd like now to talk a bit about the urgent need that we have before us, and because this is one of the central topics of today's conversations. This is my small contribution and my invitation to you that we need to devote attention to all women, all of their concerns in our communities. And I would like for us to learn a bit about East African communities so that we can act, so that we can move to action. I have just a few slides to frame the urgency of this issue. And then I have an invitation to all of you. So this is the first slide that I called from a report stating that there is limited research to date that suggests rising chronic disease incidence, barriers to access and utilization of healthcare services. But African women are at an increased risk for not receiving preventive services, cervical cancer screening, practical problems such as daycare resources, which prevent them from scheduling their needed screening appointments. There are language barriers, and there is anxiety related to completing that test because of negative past experiences and concerns regarding female genital cutting. And again, more data. The US maternal mortality crisis continues to worsen. And here's an international comparison by the Commonwealth Fund. The maternal mortality rate in the United States has for many years exceeded that of other high-income countries. We are not talking about the global South, folks. We are talking about high-income countries. Data from the Organization for Economic Cooperation and Development and from the Centers for Disease Control and Prevention show that rates are worsening around the world in recent years, as well as a widening gap between the US and its peer nations. And we know that in recent years, we have experienced prejudice, the murder of Mr. George Floyd, COVID-19, and the unveiling of how terrible our health inequities are, to name just a few. And data show that the maternal mortality rate in the United States is more than 3 times the rate in most other high-income countries, and it's getting worse. And the rate for Black women is 3 times higher than for white women. And that deaths from complications related to pregnancy in the US can be reduced by ensuring that all women have access to primary care, expanding and diversifying the maternal care workforce, and providing access to comprehensive postpartum support. The way that the maternal mortality rate is defined by the World Health Organization is the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of the pregnancy, from any cause related to or aggravated by pregnancy or its management, but not from accidental or incidental causes. So this is data collected by, for all countries from the OECD health statistics, as well as the collection of the US maternal mortality crisis continues to worsen, an international comparison from the Commonwealth Fund. The US is facing a maternal and infant health crisis, and it is fueled by the health equity gap in our healthcare system. We advocate and maintain strong relationships with Congress and administration so that we can ensure the passage of a wide range of key maternal and infant health reforms. We need to increase access to quality health care. We need to advocate for access to quality, high-value, private health insurance and public health coverage, as well as programs that provide integrated care services, that we support healthy women and babies, that we support a broad range of policies and programs to promote health, improve health equity, prevent disease, and further patient safety and prevent infant mortality. We need to improve research and surveillance. We need to advocate for innovative medical research and robust health surveillance programs. So where are the resources for this unique need? Talking about East African women, I'm talking specifically about Somali women and those who share in that experience. I did a bit of a research because I would like to invite you to participate in 3 meetings, which will be dated later. I need to consult with Fartun Welly and make sure that she is in support of this invitation, so that we can start talking. What questions are we not asking? Who needs to be at the table? Who are the people who are the best to share their experience, their lived experience, their wisdom, and their knowledge? Who can inform the field so that the services are responsive, they're culturally appropriate, they're sensitive, and they are compassionate? So this slide is just a small list, a very short list. I'm calling this that we form a study group, so that in this study group, we study, we learn, we teach and learn from each other, so that we can come up with recommendations to address them in a way that addresses the unique needs of East African women. Thank you very much. Enjoy the rest of your day. I wish I could be there with you, but I know it's going to be an impressive day. Thank you.
So amazing, so amazing. Thank you so much for Dr. Antonia. Just to go back to a comment we missed earlier from Isuroon Fartun's session Oladi, Dr. Oladi commented that being a medical provider, not an OBGYN, and hearing about these cases is very upsetting. No one needs to be treated like that. We definitely need to educate our medical community. Thank you for what you do. No, thank you for recognizing that, Dr. Oladi. Going back to what Judge Lejeune talked about, no, excuse me. What Judge Lejeune talked about, a lot of the times the burden of representation and the burden of advocacy and advocating for ourselves is put on the victim. I just remembered Nurse Anna mentioned, and it shouldn't be like that. It's a disservice, and we need to do a better job of creating systems and procedures that serve our women better. And as we wrap up this inspiring and informative event dedicated to maternal and child health, I want to express my deepest gratitude to all our speakers, participants, and oh, sorry, Mary will not be speaking anymore. We can just exit that out. Thank you. Yay, we're doing good on time. We have good 6 minutes to spare, so we'll be ending early today. I want to express my deepest gratitude to all of our speakers, participants, and supporters who have made today's conference possible. Your contributions, insights, and commitment to improving the health and well-being of mothers and children is without not noticed. I encourage each of you to take the learnings and inspirations gained today and continue to champion the cause of maternal and child health in your respective spheres of influence. Again, we will be sending out ways to connect with our speakers and the resources that they've provided via email. Thank you again for joining today. Wishing you all continued health, strength, and empowerment. Until we meet again, take care and stay safe, everyone. Yay, we got to end 5 minutes. Enjoy your Friday. Enjoy your weekend. Thank you so much.